So good afternoon, I was going to say good evening. Good afternoon, ladies and gentlemen, and welcome to the Scrutiny for Adults and Health. Welcome if you're online and you're here. I don't think we've got technically any members of the public, but welcome to those of you in the room and those of you online. I'm Graham Oakes, I'm the Councillor for Yeovil East. I'm the Vice Chair of this committee. I apologise now, let's get that out of the way. You came to see Jill and she's not here today, unfortunately, so I'll muddle through and do my best. The agenda pack with papers is available by the mob or directly from the council website from the link which was sent out to members. In line with recommended meeting procedures, I'm going to request that all members and officers turn off all microphones and videos, but please remember to turn them on when you want to speak, otherwise it's so embarrassing that Graham, you're on mute again. This helps with background noise, call quality, and anything disrupting the meeting. When I invite somebody to speak, you should clearly state who you are for the benefit of anyone who's listening to the meeting, and so they also can identify who you are. Please, can I ask? No, right. Please can I also remind committee members to use the chat function solely for committee business. Otherwise it's distracting if there are other questions or conversations happening. I'd like to warmly welcome any members of the public and the media who are joining us today. As agenda is now viewed electronically, could I request that members and officers refer to page numbers from the published agenda pack to assist all present in finding the appropriate information. And finally, there has been a change in the running order, my fault. Committee item 7, which is Crime and Disorder Overview Report, will now be the final item on the agenda. This should allow the member to attend, which will be good. So let's start. Apologies for absence.
Thank you. So we've had apologies from Jill Slocum, who can't be here because she's on holiday, and Christine Lawrence is being subbed by Martin Whale. Andrew Govier is on leave. Ben Ferguson has a centre sub, Edric Hobbs. Emily Pelson, centre sub, Henry Hobhouse. And John Bailey should be joining online.
Simon's attending as a member of a committee anyway, because we've got an item that it goes beyond adults. Minutes of the meeting, which you've all had copies of. Are you happy that I signed them as a correct record? Well, I was here and I'm happy they're a correct record, so thank you.
That's fine.
Yeah. Declarations of interest. If any members beyond your memberships of other councils already is a public record, so anything else, anything specific on the agenda? Okay, thank you very much. Public question time. There are no public unless they're hiding behind posts in here. No public. What about online? Do we have any? No members of the public online either. So we'll move past public question time. Item 5, the work programme, which is pages 17 to 22. This is to consider whether we add any new items to our already overworked work programme. Members, you've all considered this, of course, before the meeting. So have you got any items you wish to add to it? Right, clearly you have all read it and seen the scale of the work that we're going to try and achieve, which is greater than the amount of time we already have. So I think we'll just move forward unless Mel wants to add something.
I think there are a couple of items that probably aren't on here that I think have been agreed. So we've got the Somerset Safeguarding Adults Board and a report, and the My Life, My Future to come, and I think that's, yes, okay. I think they're due to come in October, but then if you look at the October list here, it's slightly different, but just to be aware of that.
Members will note that both those items are on the overall list of things we've got to do. We just don't have a date for them yet, so that's good. The sooner the better. Okay, we'll move on. The Somerset Strategic Drug and Alcohol Partnership, the annual report. Alison Bell to present.
Good afternoon, and officers, no members of the public. My name is Alison Bell. I'm a consultant in public health at the council, and it is a privilege to present the annual report of the Somerset Strategic Drug and Alcohol Partnership. I'm joined by some colleagues who I'd like to introduce at the beginning, so you know who you've got sat in front of you. So I've told you who I am. I'll hand over to Jodie.
Everyone, hi, my name is Jodie Redding. I'm the manager for the Somerset Drug and Alcohol Partnership.
Hello, my name is Justin Huggins. I'm Senior Operations Manager for Turning Point and manage the Somerset Drug and Alcohol Service contract.
Good afternoon, my name is Joy Gamlin and I'm the Operations Manager.
And online we have Superintendent Lisa Simpson.
Good afternoon, I'm Lisa Simpson. I'm the Area Commander for Somerset and North Somerset, and I have a role here as well in the Somerset Drug and Alcohol Partnership. Apologies, I'm not in the room, I'm on call, which is why I'm trying to look at two screens. I am listening today.
Okay, so without further ado, we don't anticipate going through the report in detail.
Will you might nearer to me and speak?
Oh, sorry, I was distracted in the room by the hand signals.
Yeah.
Okay, so yeah, I'm not going through the report because it's all in your papers, but what we want to do is give about 10-minute overview of the progress we've made, and then about 20 minutes from the service, because last time we came to Adults and Health Scrutiny, you clearly said to us that you want to know what happens to people when they're in treatment, and what that journey and what that support is like for the commission service that the council pays for, but is provided by Turning Point. So without further ado, Jodie, next slide, please. Okie doke. So just to give you a quick overview, there's a national landscape to this work. Dame Carol Black published a kind of a groundbreaking report that looked at the harms caused by substances and said we need to take a different approach. In the UK at the time, we were criminalising people for using substances, and actually what we needed to do is improve access to high quality specialist treatment. So in December 21, the previous government published a 10-year drug strategy, and the aims were to cut crime and save lives. What we're seeing is an increase in drug-related deaths and in alcohol-related deaths. Unusually, money was also released nationally and awarded to every local area in the country. And with that money came some ambitions around increasing the number of people in receipt of specialist treatment. And the targets, just so that you help understand the challenge that we have, is to increase the number of children in treatment by 50% from a December 2021 baseline, and increase the number of adults in treatment by 20%. So it's really, really challenging. So this additional funding sits alongside the public health grant funding and some additional funding we get to provide support to our rough sleeping community and homeless community. Next slide. So what we did when we get a national strategy, we don't just blindly jump in and go, well, let's implement it. In Somerset, we started a conversation with our partners and said, what do you think are our local priorities? Initially, it was a drugs only strategy, and the strong message from our partners in Somerset was actually, we have as many problems and as many people in need who are dependent on alcohol as we do dependent on illicit drugs. So we very quickly changed our local strategy to support people who are dependent on alcohol, who are dependent on illegal drugs. And we wanted to take a preventative approach. So a lot of the work is targeted towards stopping people becoming dependent in the first place, and harm reduction. So just saying to people don't do it isn't very effective. So trying to minimise the harms associated with use. big area of focus is the second priority around increasing access to specialist drug and alcohol treatment. And my colleagues will talk in detail about that. There was an enforcement strand, which Lisa will be happy to answer questions on at the end of the presentation. But obviously, by turning off the tap and the supply of drugs, you can very quickly help engineer it to be harder to use drugs. Alcohol, much harder, because it's a socially acceptable drug available everywhere. But as an authority, we actually play a role in licensing. I think I thought. And actually, the journey for people who use substances is one that sometimes will end up in recovery, but you might need to go back into treatment. So we wanted to raise the profile of our recovery services and ensure that all agencies, not just the Specialist Drug and Alcohol Service, were aware of the recovery offer. And actually, there's a recovery offer in almost every community in Somerset at almost every time of the day and night. One button. Next slide. I'm trying to remember all the buttons I've got to push. I don't know. Oh, I'll do this. I don't know if you can see this, but the graphs are in the report. And really, it's to give you an idea of how we're doing in terms of those ambitious targets. So we were unusual in Somerset. We got the biggest chunk of money in the last year. Other areas got the biggest chunk of money in 22-23. And actually, in Somerset, we had a policy that during the pandemic, our drug and alcohol treatment service didn't discharge people. They looked after them in the service. Other areas didn't. So for some areas, December 21, their baseline was really low. But for us, our baseline was quite high because we'd kept people in the service because we didn't want to discharge them in the middle of a lockdown. Seems to make sense to us, but other areas it didn't necessarily make sense to. So you'll see the dotted line is the trajectory, and the fixed line is actually where we're doing for now. So on the left-hand side is the increase in numbers of adults in treatment, and the graph on the right-hand side is the number of young people in treatment.
Alison, can I just pause you just for a second, just when we got to the graphs, and I love that, but I've got a hand up from one, and I want to check because I don't want questions to the end. I don't want to make sure that there's not a technical reason like you can't hear or anything. Christine, can you hear us?
Yeah, I'm happy to wait till the end, but I am concerned. It's a great report, really full of information, and the growing needs make me really think funding is going to be extremely tight. Now, I know this, and that might happen throughout the whole meeting, saying the same things, but I am concerned that this is such a specialist area and the needs are growing that funding will become increasingly more difficult.
Can I just be clearer with people? When I say I want questions at the end, that's kind of where I'd like it to go. So we'll call you back in at the end, okay? But we want to get back to Alison. Thank you.
Okay, thanks, Councillor Lawrence. I'll answer it at the end, as instructed by the chair. The other part of the our performance story is that it's not good enough, we don't believe, to just get people into treatment and tick a box. Actually, the purpose of people coming into treatment is that they successfully recover, they complete their treatment, and they go on to doing whatever they want to do. And so the bottom set of graphs are our rate of successful completion. And so the pale blue line is where Somerset is, and we're higher than national average for successful completions of treatment without representation. And for those people in treatment, showing substantial progress. So I'm going to hand over to Jodie now.
Thank you, Alison. So I, as a manager of the partnership, I was just going to give some kind of headlines around the different work streams that we are working on across all of the agencies that are part of the partnership that are sort of contributing to that overall kind of statistic and the data that you've seen on the graph. So in terms of the activity, we've been doing lots of drug and alcohol related campaigns. So some of you will be aware of campaigns like Dry January, Alcohol Awareness Week, Recovery Month. They are all national campaigns which we support locally and use that as a platform to try and increase people into treatment. We've done lots of work around that. as well as developing an intervention around how to support people who are using alcohol problematically, like a brief intervention essentially for our partners to deliver to their service users. That's a new sort of training module that we've developed during this second year since the partnership started. And colleagues from SDAT will talk a bit more about this in detail in a moment, but we've had a real increased uptake of people doing the naloxone training and distribution of naloxone kits and the availability of naloxone across the county. So naloxone is a medication that's used to reverse the effects of an opiate overdose. So it's really critical when we're thinking about one of the other headline drivers for the partnership, which is about reducing drug and alcohol related deaths. So Justin will talk a little bit more about that in a moment. In our second year, we've developed, we call it our ELDIS, which is our local drugs intelligence system. So that is around evolving a process using a multi-agency panel to review and assess and respond proportionately to any intelligence relating to drugs and alcohol and potential risks associated with that. So that's something that we've evolved in year 2 and are looking forward to kind of implementing as we move forward into year 3. Across the whole partnership, we've spent an enormous amount of time working on our continuity of care work, and continuity of care is the phrase that we use for when people are in custody, receiving drug and alcohol treatment in custody, but then are released into the community and still need drug and alcohol treatment. And it's about pathways within those two processes and how we make sure that there's some consistency in terms of the support that people are provided within that context. So we have finished, we've done a really in-depth self-assessment in terms of what we need to do to make that better. And we've had lots of partnership, multi-agency engagement in that across the partnership, as opposed to it being solely treatment service led. We have had an increasing number of people in the courts who have been sentenced to community-based rehabilitation orders, which are managed by probation. So some people who perhaps may have been sentenced to a custodial sentence have been diverted to community rehabilitation processes that are managed between probation and the treatment service in terms of there being a more rehabilitative dimension to their care. And in terms of recovery, one of the other big pieces of work that we've been doing is around peer mentoring. So the service, we commissioned them to deliver peer mentor training. So people who have been in treatment themselves, they've had their own treatment episode, then trained to become peer mentors to support others. And I think initially, when I first came into post, sort of in the early days, a lot of those peer mentors were used internally within the treatment service. Whereas increasingly this year, now the partnership has formed and everybody's working well together, we're seeking other opportunities within other services where those peer mentors can be used to try and encourage people to come into treatment, support them when they are in treatment. So we're really expanding that side of things. There's also a service in the area called Dear Albert, which is a mutual aid facilitation program. So mutual aid, some of you will be aware, Alcoholics Anonymous is the most common support service that people are aware of in the community, but there are lots of others that are similar to that. So Dear Albert are an organisation who provide an online course for people to try those things out with a view to them having longer term recovery in their communities once they've finished their specialist treatment episode with the specialist service. So we've had 45 people graduate from that, of which 89% of them went on to sustain some ongoing recovery support in the community, which is the most likely way that people who abstain from drugs and alcohol after a period of addiction can maintain that recovery, which is great. And we've also had much more activity and involvement from our peer mentors with us as a partnership ourselves. So we've got peer mentors on our board. They attend lots of working groups. We consult them on almost everything that we produce. There's a real steer toward using people with lived experience or experts by experience to try and support the work that we're doing. So we're really trying to embrace that and make that really meaningful. So there's some of that's like an overview of the strands of what we've been doing up until in year 2. As we look forward to year 3 in terms of priorities for this year, we're nearly halfway through, aren't we, now in August? But what we're actually looking at now is having a look at targeting the people who are using alcohol problematically and those in the criminal justice system who need support. We know there's a need there, and an increasing need for people in those contexts who need a bit more support. We've got a target of reaching 47% for our continuity of care. So that's the prison releases that I mentioned earlier. We need to make sure that at 47, that means 47%. I'm really confident, I'm quietly confident about this one in terms of reaching that 47%. We are working really closely with the NHS around a potential pilot for a local detox initiative. There's that work stream that is going likely to progress this year, year 3. And talking about recovery again, we're looking to make sure that we can increase those referrals to that Dear Albert provision that we talked about, because we know that that's the stepping stone for people to move on to longer term recovery. So we're really hoping to have a push on that. We're looking at having a multi-agency sort of drug and alcohol related deaths review process. So lots of organisations in our partnership. We haven't actually talked about those specifically, but from police, probation, NHS, treatment service, DWP, they're all represented on the partnership, and lots have their own organisation specific review processes. We're just trying to pull that together a bit more closely so that we can have some real system learning around drug and alcohol related deaths. And I mentioned the eldest, the intelligence system earlier when I was talking about the projects. What we're really hoping to do this year is that we really embed that and have a really prompt response to any contaminated drugs in Somerset. So people may be aware in the press of the synthetic opioid picture, and we just need to have processes in place if we find ourselves having to manage anything around that in our county. That is a snapshot from me. I'm going to pass over to you just to talk a bit more about the service.
I'm going to talk a little bit about the service. I'm going to talk quite fast.
Bring the mic nearer to you.
I'm going to talk quite fast because there's quite a lot that we're involved in, and I think it'll probably be more useful to have questions and to have the opportunity to answer those questions. So I'm going to give a very quick snapshot of what we're doing in Somerset Drug and Alcohol Service. So the team is made up of. So the team is made up of in the middle of the core team. So where we're working predominantly with adults who have a problem with either drugs and or alcohol. That can be drugs such as sort of heroin, which you might, and crack you may have heard of, but also some what we call non-opiate drugs, non-opiate drugs. So there's the things that are maybe more likely to be used in a nighttime economy or festivals, those sorts of things. So it can be a mixture of different substances. Within that team, two areas where we've really used additional money to sort of grow is one within the harm reduction and rough sleeping team. So to really try and get the service sort of more out there everywhere, working alongside colleagues to work with the people who are sort of furthest away from treatment, sometimes geography wise, but also in their sort of process around how ready they are for change. So we're really taking the service out to them. And then also within our criminal justice team as well. So before this money, we worked with people in the criminal justice system within the core team, and now we've got a specialist team of workers that will work with people who are either working alongside probation, where there's a drug or alcohol problem, or where there's a specific order from the court to work with these people where they're sort of conditioned to attend. And then as Jenny was saying, also working alongside we don't have a local prison, but we're working alongside the prisons where our residents are most likely to be discharged from, so Exeter Prison, Bristol Prison, and then Eastwood Park. So really working alongside them, going into prisons and assessing people there so that there's no gap between their treatment. So we can assess them while they're in prison and then pick them up on release. And I'll talk a little bit about that with our peer support at the end. And then we've also got a clinical team which sort of gels lots of the things together. So we employ doctors, nurses, psychiatrists, HCAs to provide sort of like that clinical and prescribing type things, but also things like fibre scanners and doing bloods for people to see if there are blood-borne viruses and then get people into treatment. So there's a vast array of things that we're doing from that clinical perspective. And then we've got a young people and family team, which I'll talk a little bit, I've got a bit more detail on a different slide, but basically the team work with anyone who's under 18 who's got a drug and or alcohol problem, whether that's their own problem or where there might be a sibling or a parent might be experiencing a problem, and then we're supporting around that. And then we've got some work that we do with, sort of, I suppose we can describe as concerned others. So whether that's a wife or husband or parent or carer who's concerned about someone else's drug use. And then we've also got a family safeguarding team within there. So we've got 8 workers that are embedded within social services where we're working with the parents who have got a drug or alcohol problem, and that there may be some form of sort of care proceedings going on, and we're supporting the sort of social work around that social team. So it's quite a big team. The adult team, as I said, we work predominantly with over 18s. We provide the prescription. So I'm going to have to flip between glasses and no glasses. I'm at that age. Prescribing services and where we're providing substitute medication for people. I won't go into detail about what it's about, but there's a number of different treatment options that people can have. And then the harm reduction services, so we provide things like needle exchange, which as well as providing people with clean and new injecting equipment, which means that they're less likely to share and less likely to then contract diseases. Also, it's an exchange, so we're taking the used so we're taking those used syringes back off people, and then they get sort of incinerated and disposed of in a safe way. That team works with people in a sort of tailored, making a tailored recovery plan. So really trying to make it about the client and their journey and at their pace. And then we've got some specialist workers as well within that team. So women's workers, criminal justice workers, engagement workers, and dual diagnosis workers. So the women's workers work with women that have additional sort of complexity in their lives. So it might be around domestic violence, it might be around being around the sex industry, all sorts of other sort of complicating factors. And then the engagement team are, as I mentioned earlier, they're trying to engage with people who are really struggling to connect with us, so we go the extra mile to try and get them into services. And then dual diagnosis is around working alongside our mental health colleagues in often within secondary mental health care, so within the trust, where there's a mental health problem and a drug and or alcohol. So we provide structured psychosocial interventions, which is basically like talking therapies. And we can do that in one-to-ones, we can do that in groups, we can do that face-to-face, and we also do quite a lot online. So we've got groups in sort of like the east and west of the county, but then we've also got those same groups replicated online, so people can join on a similar sort of technology that, as we're using today. That's just right. So the criminal justice team, I talked a little bit about that a few times, but we're really that's one area where we've really grown, and working with people, working alongside probation and police and the courts to really try and make sure that there is an option for people to seek treatment rather than just being sort of incarcerated and providing that support. But obviously it's we're part of that system, so we do report back on attendance and engagement. So if someone isn't taking that opportunity, then they will be sort of dealt with in a different way. This is just a map of some of the locations. So we've got some sort of fixed hubs, Taunton and Yeovil are our main hubs, and then we've also in Street and Frome, and then you can see some other places where we use sort of other people's buildings. So say in Bridgewater, we've got a clinic where we're running sort of 3 days a week currently. That seems to be 5 days a week. And then and we're sort of trying to spread ourselves as far as we can across the sort of Somerset region, really. So sometimes it's within other people's buildings, sometimes it's community centres, and sometimes it's in GP surgeries, those sorts of things. What's not on the map is things like pharmacies and other partners where we work from sometimes. We talked a little bit about naloxone. So naloxone is, it's really important at this point in time. I don't know if you see what's going on in America with the overdose rates with synthetic opioids. That seems to be arriving in this country like now. So there was a a number in Bristol, sort of over a weekend, so not very far away. In Leicestershire, there was a number of deaths, again, not only a few weeks ago. So naloxone is, is a lifesaver. So we've really invested quite a lot of time and effort into making that really available. So we worked alongside the police. So Somerset piloted for Avon and Somerset the training of police officers, and then giving them naloxone, so they're able to now they're trained to carry naloxone, and we know of at least 4 times that's been used in the last year to save the life by a police officer. So we've done some really great things working alongside our sort of partners. We've also got, and I encourage you to download it, we've got a really great app that where you can download it, and it will take you, it uses Google to tell you the nearest place you can get naloxone. So we work alongside pharmacies. We've got about 20 odd pharmacies, 25 pharmacies that are currently delivering, able to give people naloxone. That's again quite novel in Bristol. If you need naloxone, you go to Bristol Drugs Project, 11 Brunswick Square. In Somerset, we've got our hubs and those 25 pharmacies that are also doing it. So the app will literally use Google Maps to tell you the closest place you can get naloxone to you, and then the pharmacy will train you into how to use it. And also the app does things like it tells you how to use it and shows you videos of it being administered, and then to replenish it if you want us to sort of send it to you. We've also got a click and deliver service for naloxone, where again, if you've got a Somerset postcode, you can use an online form, and then we will send it to you, and it will be sent to you very quickly next day. Family safeguarding we talked a little bit about, so that's around the work that we do with alongside colleagues in social services, children and people services, where we're working to try and support drug users, drug and alcohol users who are also parents to improve their parenting and to reduce the impact of substance use on them and their children. And then our young people service, so it's part of the service I'm particularly sort of proud of, in that we've got a really great team of staff who work incredibly flexibly with people. So although it is up to 18, we actually continue to work with people up to the age of 25 if there's been a history of being in care, or there's a neurodiverse need or another need for them to remain in that service where they wouldn't particularly cope with the adult service. It's very person-centered, and we go out. We don't have a young people's hub. We're in people's homes and seeing people in the community. But we also do. Family support. Again, I mentioned this briefly. We've got both online and in-person family support groups. So if you're concerned about around someone you care about drug or alcohol use, then you can access support. And it's a really big part of what we try and do, trying to join those things up, because treatment shouldn't sort of operate like an island. We should be part of the community, and in a sense, people's recovery really depends on the people around them also supporting them. So really supporting the parents or carers or wives or husbands of someone who's in treatment can really be a big difference in whether they succeed or not. Okay? And also, it's a very difficult place for the individual. So even if the person isn't wanting to get change at this point in time, actually supporting the people who are sort of often picking up the pieces and impacted by drug or alcohol use is really, really important. 2 more slides. So we do a quarterly, I think it might be bi-monthly now, but or about to be, newsletter. So telling people what we do, and there's 2 recent ones, one about harm reduction, one about Alcohol Awareness Week. And peer mentors. Unfortunately, we were going to have some peer mentors here today, and then the 2 of them weren't able to make it. So Jodie mentioned that we've had peer mentors in the service for ages, and it's really, really great. But what we've now done is we've got our peer mentors embedded embedded within what's it called, DWP. So the job centres. So people go to job centres can also speak to our peers and come into treatment, and also we're doing a pick up from the gate prison service. So the day someone comes out from prison, a peer mentor meets them at the gate and then gets them to their first appointment, rather than, cause often that's where we do so. And that was sorry, took too long, but it's we do quite a bit, and it's yeah. Much of a
Okay, so sorry for talking so long. There is quite a lot to say, and we've only given you a little snapshot. But if you had the time, in the report, there's some links to some YouTube videos that tell the story of what it's like to be in treatment, and actually gives you some hope about recovery. Because most of us have got people in our families or ourselves have been touched by this, and it's remarkably more prevalent than we imagine. So actually be that person that reaches out to someone you know struggling. I know there's a really good service that's rated by CQC as good in Somerset that can help you or help your family member, and have a look at the YouTube videos. Thank you for your time.
Thank you. It is a massive subject. You actually, I think, did very well to get in what you could, slightly over the amount of time, but well done. And Christine was first in the batting order with her question. Do you want her to repeat her question? No? Okay, Alison.
Yeah, so thank you, Christine, for the question. Just to summarise, it was about your concern about funding for this service. So before the external grants, the public health grant funded this service. And for those of you who don't know, the public health grant in Somerset is one of the lowest per capita public health grants in the country. So we funded the drug and alcohol service. We're mandated to do that, but that grant doesn't get any tariff inflation. So since 2013, the grant hasn't really increased, but the price of staff and the price of drugs has. So it's a challenge every year to bring this service in within budget. We were blessed in 2022 for 3 years to get additional funding through the SSMTRG. We got $500,000 the first year, 880,000 year two, and this year we had 1.4 million. We don't know what's happening after March 25. And on top of that, we got $500,000. Well, Mendip got a couple of 100,000 in year one of the rough sleeper grant. And then when we became unitary, the whole of Somerset got twice that, even though we're 4 times as big. Then I can do maths. So again, we don't know what's happening to the rough sleeper grant after March 25, and the inpatient detox grant, which provides inpatient rehab and detox beds through a consortium at Broadway Lodge in North Somerset and the unit in Bristol. We don't know what's happening to that 70,000. So we're planning for a range of scenarios. One is that we won't get any money, and one that we'll hopefully get the same money. But we have heard rumours that this is supported by the new government. It was a cross-party strategy. All parties agreed with the strategy. So we're hoping that we get beyond 3 years of funding of a 10-year drug strategy, because otherwise it's going to have a big impact. And as Christine highlighted, the demand's going up, not reducing.
Thank you. Sue Osborne.
Thank you, Chairman. I was particularly interested in the use of naloxone because, as you say, that is something that's common practice in some parts of the US. And I did see a documentary once on that, where they were just going around particular areas and just treating people. What I'm curious to know is that when you treat someone with naloxone, what follow-up is provided to that person? Because there's obviously a problem there, and this might be the first time you know of that particular individual. So what follow-up is provided to those who are treated? What records and data is being gathered at the moment? How many people are you needing to repeat treat? And how are we dealing with those? Those would be my questions on that.
We're going to do a double act. This is a common practice. So in terms of how people access naloxone, here's mine. I've done my training. All of us have got it. So if someone's treated with naloxone, they'll be supported to access medical treatment. They don't always agree, but you know, ambulance service, police, they'll try and get someone, because this is an emergency rescue medication.
Yeah.
It only gets you over the hump. You need to wait until those drugs are completely out of the system. And you said about repeat treatment. Actually, we've had a number of people in Somerset that have needed 6-8 doses of naloxone to just get them back to consciousness and breathing because of the contamination. But just to
Yeah, I mean, it's particularly, so within that, what you're prescribed, what you're given, there's 5 doses in there. Normally we would, if you only need one, we would then encourage people to dispose of that, you know, to bring it back to us, and then we'll issue them with a new kit, so they've got a whole new kit for next time. But as I was saying, with these super strength synthetic opioids that are now coming in, you know, there's anecdotal evidence of people needing sort of 6 to 8 doses, so more than what we're given. So we've taken the decision to issue everyone with 2 kits rather than just the one, which is obviously more expensive, but it's, you know, there's no point having a kit that's not good enough to get you through. So and we're doing very well in the numbers of people who are in treatment with us for opiates or heroin-like drugs is really high, in the 90% have accepted one of these kits. Where we're now focusing on is the people who are out there that are not necessarily in treatment yet, but it's just as important, probably more important, that they've got kits in their hands. So working with partner agencies to make sure they've got access to kits as well.
So at this stage, you've no indication as to how many kits are out there and being used. What I was referring to by repeat dose was not that you had to give someone an extra dose because they're on a super strong opioid or they've taken a particularly heavy dose. It was the number of times where you treat that person and how many times, you know, maybe a few months later, you're back again treating that same person. And yes, they may well have to go in hospital because you say that's the emergency first aid, but it's what follow-up is offered after that to sort of try and get that person to maybe realise that, you know, you can't go on like this, and, you know, to get them into rehab or into some of the programmes that are on offer.
we last June, we had some workshops between the Drug and Alcohol Service and both hospitals, because actually we absolutely recognise that there's people that aren't in touch with specialist treatment, and sometimes we've all done this. You have a wake-up call, don't you? You have a car crash, you have an emergency admission, and it's a wake-up call that your health is not where it needs to be. And so there's an opportunity when that happens to have a conversation with someone about maybe coming into treatment. And so I think building a stronger relationship between the Drug and Alcohol Service and the NHS is really, really important. But one of the challenges is that none of the data systems join up. So someone might overdose in Devon, over the border, then they might overdose in Somerset. We're working hard with the Ambulance Trust to try and get data on the number of people that are overdosing in each postcode area, so that we can see if we've got a contaminated drugs issue. We've been trying for 1.5 years. We'll keep trying. I'm being told it's on its way, but I think at an individual level it's hard, but at a population level we need to see how many people are overdosing.
Councillor Hogpage. Oh, sorry.
It was just to add, so yeah, it is, I think as no one heard, it's a massive window of opportunity to them to do some work. The challenge is that there's a shelf life for this medicine, so it's normally about 3 years. So quite a lot of people are on their second or third kit because they've been with us a while, and some people lose a kit, other people use a kit, so it's really hard to. So we do ask people if they've used a kit to save a life, then there's a process that we go through to sort of debrief them and to sort of understand what happened and to, you know, give them the back. But it's hard. The data's hard to sort of know exactly how many kits have been used to save life, because you're replenishing them for lots of different reasons as well, if that makes sense.
Yeah, I know it's a bit of a challenge, and it sounds quite a challenge, but I think it would be really helpful to have some data next year to back up reports in terms of how many people received it, how many went on to rehab, were subsequently successful because they'd had that brush with death. just the documentary I saw somewhere in California. They were just giving people naloxone, but there seemed to be no sort of follow-up. It was almost as though you're treating a symptom and we'll keep doing that rather than actually trying to give people hope and a route out. So I'd say it would be useful to know how many people are being treated, how many people are repeats. I don't mean just that you keep giving them more because the opiates are getting stronger and stronger and cheaper in some cases. You know, as that to me seems like a symptom, and it's almost could give you an indication as to just the size and scale of the problem we're dealing with. And are any particular parts of the county affected more than others? So therefore, we're going to need more resource to deal with that problem than perhaps some others.
Yeah, so Alison talked about that data that we would like from the ambulance service. So for 1 quarter during the pandemic, we were able to get hold of that data. And it was really interesting because there were lots of non-fatal overdoses that we didn't know about in Minehead, and so we were able to then target that area to do some additional outreach work and to try and really try and sort of engage with our community. So so that data is like gold, but unfortunately we only had it for 1 quarter, and then we're asking for 18 months to try and get it. But yeah, we will keep trying.
Yeah, what's the reason for that?
I'm not entirely sure.
That's a shame because if they can deliver it for 1 quarter, I'm sure they can keep doing because it sounds like a viable source. And if you are going to be struggling for getting funding for these initiatives, plus what sleepers, plus everything else, this is the sort of hard data you need to be presenting to central government to make sure they don't slash our funding.
Gee, I think that's probably the best answer I've heard, and then since I've been on scrutiny from an officer. Actually, I'm not sure. Is very reassuring. Just to make the point that before this, the figures were different because these people died in many cases. Councillor Hobhouse.
Thank you, Mr. Chairman. I have 2 completely different questions. In South Somerset, we were using Bournemouth churches, and we had Yeovil pretty well clear of homeless people because we had our own. Without a government grant, we had our own shelter for people to go to. What is the situation now? Do you have the funding, and are you able to keep the service going the way it was? And that's my first question, Mr. Chairman.
Okay, so when I was talking about homeless funding, Councillor Hobhouse, it was for drug and alcohol treatment. It wasn't for the homeless provision. Okay. So I'm afraid I can't answer that because it's not a public health grant funded. But if you want, we can find a right officer too.
No, I thought you had the 2 combined because you never made it clear, and I'm only a substitute on this committee. I apologise. My second question concerns the area I live in, which is Wincanton and Castle Carey. We have no treatment, we have no police, we only have PCSOs. We have reported drug abuse and dealing, and we haven't had nobody dealing with it in the rural areas. How do we go about getting people who are known drug dealers put into your system from the rural areas which are not part of the conglomerates and the towns?
Yeah, okay, so I'm giving Lisa a 1-minute warning. I think she's come on camera, but in terms of the proposition that there's no treatment in Wincanton, that the drug and alcohol service isn't dependent on a building. So we stopped funding buildings to have treatment hubs. The treatment service is available, but the real challenge is engaging someone to think about changing their behaviour and getting into treatment. So the service is there and will meet anyone where they can, where they're able to meet. So there is treatment in Castle Carey and in Wincanton and in South Somerset. But in terms of the enforcement aspect, I'm going to bring in my colleague Lisa from the police.
Yes, thank you. Can you hear me okay? And I hope I'm not too loud. It's difficult to tell if you boom out in that room.
You're fine.
I'm disappointed to hear that the feeling with the community is there's no police, because that's not accurate. But I do understand that there'll be competing priorities and low visibility in huge areas. So I understand if that's the feeling, and I can do something about that. But we do have policing in Wincanton and Castle proportionately to everywhere else. The challenge is making sure we're hearing the right information and targeting the right areas. And it isn't just about targeting those that take it, it's about making sure we're preventing those being exploited that are surrounded by it. Antisocial behaviour is a surrounding issue around drug use. So it's about what is the issue that we feel is not being dealt with? What do we need to do differently? Is it targeting? Is it prevention? Is it a bit of both? And I suspect it's that. And I'm very, very happy to pick up with you offline exactly what you're hearing from the communities, how we think we're receiving it or not receiving it, and where that breakdown is.
Thank you. Martin Whale.
Yes, thank you. Martin Whale from Chard North. Looking at your partnership and all the great work you do, I just couldn't find any reference to the real problem of drugs, which is among the children, among school kids. We all know county lines and who runs the drugs about, and have you, or is it another partnership who actually gets to the kids and does the training and the shock to these children? Or is it, as I say, is it you, or is it Somerset Safer Partnership or whoever?
Okay, thank you for the question. And I absolutely agree with you. It's too late once a child is in treatment. We failed. Actually, we need to inform them of the risks that they're taking, and those are incredibly far-reaching. So the first 2 years of the grant, we did focus very much on increasing numbers in treatment. But this last year, we have started looking at broadening the children, young people's work. And the key is it's been called lots of different things over the years, PSHE, RSHE, the pastoral lessons that every school is obliged, actually, because this council actually wrote to the last Secretary of State and said every school should be providing it, and they did eventually agree, to deliver accurate information about drugs. As a parent, I thought the cost was a barrier, and if children didn't have much money, they wouldn't be able to afford them. But you can get a tab of MDMA for about £1. It's cheaper than water. You can get it delivered to your house. Yeah. So a lot of the misconceptions are also held by parents. So before this summer holiday, we put out a brief for all parents of children attending schools in Somerset to say these are the kind of things you need to be aware of, because we now know that vapes, the ones that you refill, they can be contaminated with spice and other drugs. So we really need to inform our children, young people of the risk, because they are smart. And they need the information to make better decisions. Yeah. We haven't made much progress the first 2 years, but Kelly Brewer, who's one of the strategic managers in children's services, has agreed to set up a starting kind of work. And we did stuff before the summer holidays, because all of you will have seen the stuff about spice in vapes, and it is absolutely terrifying. So I think we've got a long way to go, but I don't want more children in treatment. No. I want children to not be doing drugs, to be honest. They seem to have turned away from alcohol. Yeah. Which is good news, but we need them to, maybe you could convince them to cycle.
Just to add, we so the young people's team that we manage very much engage with schools, but we tend to work with schools where there's the beginning, so people who may be at risk of being excluded, and where there is maybe some evidence of county lines, or where there is some evidence of being starting to sort of mix in with the wrong crowd and stuff. So we don't tend to do as much of the preventative training, but we will do specialist groups with groups of people that are where they're starting to be a problem, so they're starting to dabble, they're starting to sort of have an issue, and then obviously we do. The vast majority of work is unfortunately with young people where they have already where there is already a problem. So we do some of that, but in a sense, like I say, the way that this system is designed is that really the teachers are the best place to do some of that. preventative work.
Lisa, you want to come back in?
Yes, thank you. Just to supplement there, also a parent of 2 teenage children in the school system in Somerset. I do know that their PSHE lessons for the last 18 months have been almost every time about vaping, and I'm not undermining the importance of that, but every single PSHE has been taken up with some sort of drug intervention. So I think there is lots of good work in there. You will know that we've just been inspected as a county in a joint inspection around serious youth violence. We can't decouple this work from the serious violence work. What that has found is that actually practitioners on the ground in all agencies are doing some such good work in educating children around the risks of exploitation, and of course drugs exploitation and county lines falls into that. So we know there's some really good offers. What it did tell us is that we're not very joined up, and we're not necessarily doing it with the same energy across each area properly. So what that opportunity brings us from having been criticised is, let's review exactly how we join it up. Let's talk about serious violence, and let's connect it with the work in this programme as well. And we've got the next sort of 6 months to really sharpen our plans to do that. So I think there's real opportunity.
Yeah, sorry.
Yes, Martin.
Can I supplementary? Thank you, Chairman. It's on county lines, actually, if the officer could help. I know there was a big operation last year, which was reasonably successful, but it always seems to be backfilled fairly quickly with another county line, etc. And I know it's a huge frustration. I know that, and I appreciate all that's done. But have you any information on any getting to the sources of the county lines, if you like, which is the real difficult thing, I would imagine?
So that's the $1 million question. Thank you for asking. I wish the answer was easy. It really isn't. It's taking we often take the head of the snake off, and then there'll be another nest of pythons somewhere else. Unfortunately, where there's money to be made, exploitation will happen in this, or whether it's sexual exploitation or violence of any sort. We increasingly have the technology to get there quicker, but so do the offenders, and this is multi-million-pound business, so they're as ahead of the technology as we are. So it's a bit of a depressing picture. That's not to say we'll let it beat us. Locally, we are a lead force in terms of our sort of drug work. We've got regional operating units that cover across the whole of our sort of borders with Devon and Cornwall and Dorset and Wiltshire, and we look at the intelligence, so we try and do cross-border work with real specialists. But the answer to taking the head of organised crime off when they've got a line working well is we do our very best, we find them, we take them out, we prosecute, we offer deterrence. There will always be someone else that wants to. We've just got to get smarter and quicker.
Thank you.
Thank you. Sarah.
Yes, thank you. I'm the lead member for adult social services. I'm very interested in what you're doing. It's a really, really helpful report. Thank you very much. I wanted to ask a couple of things. In the report itself, and forgive me, I have read it, but the man wasn't read it carefully. You didn't really sort of give us the figures for the number of people you're dealing with, and that would be helpful in the sense that if you knew what it was as a proportion of, say, Somerset, you'd know whether to feel really worried or more worried than that or whatever. I think it just puts it in context. Like, 'cause I think somebody might listen to this might think, oh, there's a terrible problem in Somerset. Well, there is, but it actually in context of the whole county, it may not be as bad as it sounds. So I don't know if that's the right thing to say. My second point was, are children of drug and alcohol abusers more likely to become so themselves? I think the answer is probably yes, which is why you need to get in and work with it. I just thought I'd ask that. But my third point, which is a different one, and it just shows my ignorance, I'm going to say it anyway. I thought that if you had a drug or alcohol or an abuse problem, you needed to get to the point yourself where you make the decision to say no or to stop. And are you saying that the services that we now provide help people towards that position, even though ultimately they've got to make that decision themselves? Because it doesn't work if you haven't decided yourself. I made that, but maybe that be so obvious, I shouldn't have said it, but I just wanted to ask that question. So you can push people towards, but ultimately they have to make that decision, don't they?
So yes and yes. Yeah, I mean that's the art of being a drugs and alcohol worker is actually trying to support people to make a really firm decision towards change. The truth is most people there are some level of ambivalence. For most people, there's some level of they're unhappy with their situation, but it's also providing some function. So that the job of a drugs worker is to sort of highlight the areas that are causing them issues and try and support them to find other ways to cope with things that are going on. So very much so. The job is we would welcome referrals from people who haven't made a firm decision yet, because that's our job to support them to make that firm decision to change. And that's the art of drugs work, is to really try and focus people to feel like today's a day I want to make a change. There's a way of communicating motivation. We're all trained in that actually. That does exactly that, really, and it's used in other parts of sort of medicine and public health as well. But yeah, so very But I think you're right. It is different than how it used to be. I think before we would say, someone's got to be ready to change before come to us, whereas now we'd rather have the conversation.
Can I just add to that also, because to me this is the whole beauty of the partnership, isn't it? Because most of these people, and Alison will talk to you about numbers in a minute, are some agencies got a touch point on them, most of them. So the key has to be, what are those external partners doing to motivate and support, facilitate referrals to the specialist service? So whether that's children's services, whether that is probation, DWP, somebody's got access to them. So we've got a specialist service for a reason, and those that need to come to treatment need a bit more motivation. There's a role there with all of it. It's got to be a systemic approach, and that's why all of the key people are on the partnership, so you can start having those discussions. You can have a touch point on these people. What are you organisationally doing to identify them, assess them, refer them, and support them? So in terms of numbers,
yeah, just in terms of numbers. So in terms of alcohol, there's modelled national data, and I can share something to go into the minutes in detail. But the headlines are really: we estimate that there's 5,000 dependent drinkers in Somerset, and about 20% of those are receiving specialist treatment. So we're a bit of an outlier. We're much worse at hospital admissions as a result of alcohol. And actually, if you talk to Lisa, her data shows that actually we have a lot of road accidents as a result of drugs and alcohol. So we think actually we're not reaching everyone that we would want to reach to support with their alcohol use. Hence why we've got a drug and alcohol strategy. In terms of the drug data, there's no survey that says who uses opiates, who uses non-opiates. So they've taken our prison population of people that have gone to prison from Somerset, our death data, and our numbers in treatment, and said, based on those three cohorts, this is how many opiate users we think there are in Somerset. We don't actually think that's right.
Nobody
thinks that's right. So the headline there is we've got, I think it's 56, 57% unmet need, which sounds really frightening, but actually we don't think that number's right. And the reason we don't think that's right is when you talk to our hospital A&E staff, who are now going to tell the service when people are presenting so they can try and engage them whilst they're admitted. There's very few people coming through the front door that STAS don't know. So, and you can't really use opiates without having the odd brush with A&E here and there, so, or the police. So I think, as Jodie said, the specialist treatment service can't do this on their own. It's the other conversations going on, but we know we've got a lot of work to do around alcohol. And the only last thing I would say is around Councillor Wells' query around children. What's most worrying is the use of drugs amongst our younger people seems very similar to urban areas. That just might be because of the modelling, I'm not really sure. But our older age groups is less than more urban areas. So lots of work to do. But I can prepare a little brief and put it in the minutes.
Lisa, you want to speak again?
Yeah, just to pick up on the road deaths piece, if that's okay. I was going to pick it up as sort of an AOB at the end, but Alison gave me a good segue there. If we're not very proud of this stat, but we're right at the top of the tree of 43 constabularies as the most deaths on our roads. We have got a huge road network, obviously. And of that, there's a bigger proportion in Somerset than elsewhere. I haven't got the updated figures for me today, but it's horrifying. People die on the roads more than in any other capacity in what we investigate. And at least a third, maybe even a half, are alcohol related or drug related. So the work that we need to do in educating our communities and sadly rural communities probably feel like there is a way to get away with it better because they're less visible to policing, maybe, I don't know, but we certainly know there's work to do out there in capturing that unmet group, because a drink driver usually hasn't done it as a one-off and usually is drinking excessively more than that one occasion.
Thank you. Two more speakers, but we're going to have to round this up because I allowed it to go on quite a lot further than we originally intended. Henry and then Mike Sam.
You need to talk to the preschools. I'm the chairman of my local preschool, and every child that comes in without boundaries, we know that the mother or the father or both is taking drugs, and we can prove that to you. And it is absolutely appalling. We have reported the dealers to the police on both 999 and 111, and we don't get any reaction at all. So I'm very happy to give you the names, but I will do it in private after this if you want them. But I seriously suggest that you look at the parental drug use, which is not hidden because the children are suffering.
I have a feeling Lisa will be coming to see Henry shortly. Mike. You want to come back?
That's right. Can you hear me all right?
Yeah.
Thank you, Mr. Chairman. Really a follow-up question to Lisa and then a comment. Those statistics, the higher rate of deaths from alcohol and drug use in Somerset, does that include traffic that's coming through Somerset on the M5 and the A303, for instance? So people will have had their alcohol or their drug consumption will have been outside the county, or if you exclude those?
I wasn't talking about anything on that point. I wasn't talking anything other than road related deaths. So please don't mistake, and I'm sorry if I caused confusion about deaths outside of a vehicle, but road related death are highest numbers in Somerset. We probably do carry the stats from where they've come, but they are wherever they've come from and who's been involved in is largely impacting our Somerset community. So a huge proportion of them will be residents within the area.
Thank you, Lisa. That's helpful because we have the same issue with atmospheric pollution. We have high measures of atmospheric pollution, but a lot of it comes from through traffic. So I just wanted to say thank you very much to the team. What an impressive set of work you do, and what an impressive presentation and report. Thank you very much.
And thank you, Mike, for summing up. It saves me having to do it because that was, I can't do better than that. Thank you very much, Time. Thank you very much for your time and your presentation. We look forward to seeing you again in the future.
Well done. Thank you.
Next item on the agenda is due regard to equalities, which means Tom Rutland has to reappear from behind that pillar.
Sound not helpful.
Oh.
Thank you, Chair. Thank you, councillors. Good afternoon. So I am here to cover your considerations around equality due regard, as set out in the Equality Act and the Public Sector Equality Duty. So essentially, we had a peer challenge completed by the Local Government Association in October last year. And as part of that peer challenge, they had a number of conversations with different individuals throughout the organisation, with our external partners and various other bits and bobs, to go, how are we functioning from an equality perspective as an organisation and as a council, and in relation to where we sit within the wider community. One of the areas of work that came out was Scrutiny's understanding of their responsibility around due regard, what that means, what that looks like, and how it manifests itself in the role of scrutiny. So I am having a fun job of hopping around to each scrutiny board to go, hello, just to remind you, there is this thing called the Public Sector Equality Duty, and the Public Sector Equality Duty says you will pay due regard in everything that you do, so that will be in your role as scrutiny, but it will also be in your role as an elected member, stop, to how we can eliminate discrimination, harassment, and victimisation, how we can foster good relations between those that share a protected characteristic and those that don't, and how we can champion, oh, I forgot the third one. That's absolutely shocking. I've been doing this for years. They normally roll off the tongue like no one's business.
See, if Jill had been in the chair, you'd have known.
I never, she would have put me off by now. Possibly related, advanced quality of opportunity, that's the puppy I'm looking for and failing to find. So how can we do that within everything that we do? I think for the role of scrutiny, it's around how you are having those conversations with the items that are being presented to you and how you are challenging those that are coming to present those items in relation to the protected characteristics and the duties under the legislation. You are not necessarily a decision-making board, but you are supporting the decision-making process. You are here to support and challenge the decisions and the reports that are being presented to you, and part of that will be around whether or not there is disproportionate impact on different groups, whether there is a way in which what is being presented might need to look differently for different groups, and what that may look like. So the item that was presented before, actually, are men or women more likely to be part of the service? Are we more likely to see representatives from different ethnic minorities part of drug or alcohol users? Are there lower numbers from those groups within the service and what's going on? How are we challenging and questioning the things that are coming forward to us to make sure that we fully understand that they're working effectively, they're engaging effectively, and they are making an understanding, they're understanding how they are accessing and dealing with different communities in different ways if needed. As a council and as a set of services, what we can sometimes do is go, universal service will be available to everyone. So library service is a classic example of that, where we go universal service is accessible to everyone. Actually, there could be barriers to people accessing that service that we don't understand, and we don't know until we look at and pull apart and question the data that we've got in relation to those to go, actually, is there a reason why they might and might not be engaging with that service? Is there a reason why they might not be able to take part in that service? And the answer may be, yes, there is, but we understand the issue, and we're more than happy with it. Or it might be, no, we don't understand that, or there is a barrier, and this is the barrier, and this is what we need to do about it. But part of your role of scrutiny, as part of the role of executive, as part of all members' responsibility around their role of full council, is to question and challenge and be confident that we're able to take the decisions that we're going to take in a way that we've understood the potential impacts and the challenges and the barriers that there may be for individuals with the services that we provide. There is a resource pack that's attached to the end of the report that provides a little more information around, okay, so as a scrutiny chair, what might that mean? What might that look like? We're also going to pull together a briefing pack for you around actually what questions might you want to ask of the scrutiny in relation to the things that are being presented to you? What might that look like, and what might that be addressing and delivered as? I will now be quiet. Any questions?
Hillary.
I just wanted to say thank you for the reminder. It's very useful. Thank you.
Martin.
It's always difficult to ask questions on this subject, to be honest, but you mentioned, Tom, that we should be looking into the various details of who is what in all our scrutiny work. Quite frankly, you mentioned the last subject, which we just dealt with. And frankly, when I was listening to that, all I was thinking about was, someone has to be injected to keep them alive. And quite frankly, my thoughts wouldn't be into who they are, what they are, the fact that they are just a person who needs the treatment. And when you said we should be putting it into everything, I find it a bit difficult at that level. That's all I would say.
So it's not necessarily about going for a specific situation, how, but it's around that context of going in relation to the service and those that are accessing the service. Is there disproportionate access within that? Are there differences about how? So if we take the drug and alcohol as the example, what are the levels of those in the drug and alcohol service at the moment, and where are they from? What types of people that we are? We know that they have an inordinate amount of data because I've worked with the service providers on what they've got access to. And we've had conversations around actually, are there certain groups where they're not seeing people come through their doors? And then that poses the question of, is that because there's not the usage within that community? Or actually, is there not the recognition of the service within that community and the fact that the service is available? Is it the fact that people think they have to pay for the service? So we know with certain ethnic minority groups, because we've done a bit of challenge in the conversation, actually the barrier is they think they have to pay for it. So therefore they're not willing access to the service because they assume once they get through the front door, there's going to be a fee that's attached to it. So there will always be, so equality is always, the way in which I like to look at equality is it's always about asking the question. It's about being able to go, could there be a difference? And if there is, what is it? Where do we go with it? And what do we need to understand? And what does it tell us?
Right, thank you.
Any more questions? It is an incredibly difficult subject that's both very simple and very complex at the same time.
Much like myself.
I wasn't going to say that, Tom, but yes. But I'm thankful that you've come here this afternoon, because actually reflecting back on what we had before, there were clearly elements where the equality issues come up. But like you say, unless you actually know the further detail of sections of the community where something isn't approached. And for this committee, we've looked at a whole range of things. And if we looked at, for example, suicide, the issues around that and the different sections of the community, there actually are issues around equalities within that. We just need to remember that when we look at these subjects again in the future. So thank you very much for your very brief but very thought-provoking presentation. Thank you.
Thank you, Tom.
And I just apologise for leaving the room, but I had lots of information to discuss with the team on drug and alcohol rehabilitation around prescribing park running, etc. So I've given my details, and there's a lot of work we can do there. So I'd like to apologise for just stepping out of the room for a moment.
A very good reason to leave the room.
Yeah. On the report.
We're just finding the recommendations for a second.
Can you bring your recommendations on your report forward?
Oh.
Tom's still here.
Don't run away yet.
I'll come back.
Can you remind us of your recommendations?
For Scrutiny to recognise and remind themselves that they have the responsibility to be able to and to be open to coming back with trainings and development opportunities.
Yes. Yes. To reconfirm the commitment to equality, due regard being part of their scrutiny function, and to support further training opportunities that are provided by the delivery of this commitment. Are members supportive of that? I really hope so. Thank you very much indeed, and we reconfirm and support that. Thank you. You may run away. Again. Ready for the
Yeah.
Now we get to the difference between those who spend and those who just monitor the expenditure. Budget monitoring report. Over to the lovely Penny, who just monitors it apparently. Oh, sorry, Sarah wants to speak first as a lead member.
Yeah, I'd just like to say that I am pleased with the report that we're bringing forward this morning. And I just wanted to make a point that was raised by one of the committee members, or I think somebody attending committee, it may not even have been this committee, about the rebasing of the budget. I think the person concerned said that that was done every year. I just want to make it clear that last year it was done really carefully, right back to basics, which is why we ended up with a huge increase, which we needed for adult social care, which probably, from everybody's point of view, put the council itself in a very difficult position, having to put that increase in. However, as Penny will now tell you, that seems to be making a change, so that we are already well overspent for the year, which we could otherwise have been. If you just put in, let's give them a bit more because they overspent last year, that just does not work. So I'm really pleased with what we're doing so far. There is absolutely no guarantee that we won't have some really difficult situations to deal with, families, people running out of money for their care and things which will make a difference to this. But as of now, over to Penny.
Thank you, Sarah. My name is Penny Gower. I'm the Service Manager for Adults and Public Health Finance. So I'm just going to talk through the month 3 position. Before we move on to adults, I thought I'd let you know that currently the council for month 3 is overall reporting £0.2 million underspend. All services. Children's have continued to see pressures in this financial year, and that's currently being looked at and reviewed. And what climate and place have also seen pressures, which you'll be aware of within the waste services. But we'll move on to where adults are now in terms of the reported underspend. So, yes, as Councillor Wakefield touched upon, we did have a big increase, £59 million from last year's budget to this year's budget. And as you can see, we are currently reporting an underspend of £2.1 million. This is broken down across, so you have adult social care operations, so you've got your physical disability, your sensory loss, and your 65 plus. We're currently reporting an underspend of 2.4 million. The majority of this underspend is due to residential nursing placements, where the cost of beds currently within this year are below the budgeted figure that I originally anticipated that beds would come in on. So, for example, residential last year, our average weekly fee was £903. We are now getting that at £825. So we've seen a big, slight decrease there. Yeah, don't look at that. In terms of, we are reporting though, overspend of 1.2 million against the equipment service. This is a pooled budget with our health colleagues within the ICB, and work is being done in this area to understand which services are actually spending the funds, the money. In terms of public health, again, we're reporting an underspend of 1.2 million. Again, this is around where the growth, so the demographic growth within this area is currently less than we were predicting. Mental health, sorry, yeah. This is currently less than what we were predicting. However, we're quite early on within the financial year, so things could change, and those placements do tend to be slightly more expensive than the older people placement. In terms of learning disabilities, we're seeing a current unprojected underspend of 0.9 million. However, we are continuing to see, so you remember this from last year, pressures within supported living and home care. And this is again around market sustainability and increased areas there. In terms of adult social care commissioning, we're reporting a £2.4 million overspend. And this is mainly due to intermediate care. So we have bedded pathways that have continued, but work is being done with Mel's team to look at future demand of those beds with the view to reduce them. Then if I move on quickly. In terms of tracking the medium-term financial plan for 24-25, as you can see, a number of these have already been achieved for adults, and we're actually reporting to be on track for everything else, including the My Life, My Future, the 5 million that was built in for this financial year, and also the 3.9 million that wasn't achieved last financial year. we're still on target, so that will be achieved this year. And the other big area of saving is around maximising fees and charges across adult social care. So the financial assessments team have worked really hard over the last year. We've now cleared the backlog that we had historically. So people should now be financially assessed within home care or community services within 15 days. So that's within our 28-day target. And residential is just slightly over that at the moment, but we are working to reduce that further. Are there any questions?
Sue Osborne.
Thank you. I was interested to see, and that whilst it's pleasing and the rebasing the budget has certainly been certainly been welcome, because it means you're then working to a much more realistic budget in terms of recognising the pressures that adult social care, being an open-ended, demand-led service, has faced. I'm interested to see that the top line, particularly on adult social care operations, the over 65s, that's showing green, but the home care is actually now red. Is it possible that in moving towards a policy of supporting people at home rather than going into residential or other supported, that we're actually seeing sort of what is in effect a transfer of funding from one to the other, that if you increase the number of people that we're going to be encouraging to stay at home and look after at home, that's going to take extra budget. So one is balancing out the other. And in terms of the equipment as well, budget having pressure on it, that could also be a result of people staying at home, or you're looking at enabling people under reablement to come out of hospital quicker, that again is going to need more use of specialised equipment where perhaps you might not have been spending before. But overall, let's see how it goes. And another part of that is in terms of predicting when people may hit the buffers in terms of running out of funding. So they then come over to us. Do we have any mechanisms in place at the moment to forecast when we're going to sort of be met with increased demand from that scenario?
Okay, I'll pick some of that up for you, and then Penny will pick any numbers that I have found. Okay, we'll do it this way. So residential care, we expected that to come in. We've done a massive amount with the market around price and around what is affordable. I think the other change in the market is, and I've said it many, many times, is our international recruits. They're not needing as much agency, therefore it is cheaper. We've also got additional supply out there because we're doing things different. So supply and demand change, and we're holding really hard to a fee price. We're managing to get that. Our home care, within our home care, we have, that's where you can see our My Life, My Future. So we've had to put that 5 million somewhere to be able to save it. So we've put it in that line. However, we always expect, our policy is less people going into residential care. Obviously, we're always going to need some nursing care, but less people go into residential care, a different solution, and people living at home longer. That's the idea. So we should be balancing out those budgets. We'll see how it goes, and we'll move the budgets around during the year just to stabilise that and manage it. In terms of equipment budget, it's a joint pool budget, so it is health and social care. As health do hospital at home, as health do other areas to support people to stay in their own homes, the cost of that budget and the cost of equipment, because if you're going to stay home and you're going to come out of hospital earlier, or you're going to prevent somebody going into hospital by treating them in their own home, you're probably going to need specialist beds, etc., etc., etc. And there is a cost in that. What we're working through at the moment is, that budget at the moment is a 50-50 split between social care and health. We're working to really be clear about what part of that is a social care element, what part is a health element. And we're just working that through so that we can manage that for next year, and we will do that in that space. However, what we do know is reablement, we keep people at home longer, it costs us to deliver it on equipment. But it is cheaper to provide equipment than it is to place somebody in a setting which is inappropriate for them.
Yeah.
I think that's a good one. The other thing we're looking at in that space is also about what type of equipment are we giving people? There are lots of equipment out there. Are we going for the gold band, or are we actually doing the thing that makes the job work? And alongside that,
are we ensuring that we are recycling our equipment as well as we can? So there's some areas in there. So I'm expecting to see that come down during the year, the overspend, because there's work alongside this.
Okay, and then in terms of capital drops or depleted funds, which is a term we want to use, we've seen the dramatic increase probably in the definitely since January. So historically, I would look at trends where we've seen it across the previous years. Like I say, since January, we saw 100 between January and the end of March. That's dramatically more than we would have seen previously. And as our fees are slowly increasing, obviously some homes are having to charge private clients the difference to make it up so that they can be sustainable. So people are dropping into us probably quicker than originally anticipated. So I'm currently now going to begin MTFP for next financial year. So we're going to be redoing that model, and I'll be really looking at the way that we look at and predict those capital drops.
Okay, thank you. And the other part is paragraph 413, key risks, future issues and opportunities. You've mentioned in there as well that there's a risk that this particular budget could increase, and you commented that the international recruitment landscape has changed, and you don't know what effect has been. What has been the changes to that international landscape, and how we're going to sort of mitigate any risks from that changing? Because clearly it has had an impact on performance.
And I wish I could influence that. That's not my, that's immigration law that's changed, which has said that people cannot bring their spouses or relatives with them. So what does happen, and rightly so, is people come across, they start working, and they bring their families with them. It's that bit that has changed. I do not know the impact of that at this moment in time. We'll have to wait and see what that does, and we really don't know. And I think so therefore I am highlighting that as a risk. If that changed, it is that international recruitment market alongside our own labour market. So we've got to, there's both in here. But it's about how do you do that, and that's helped us because we don't need agency. We've got a lot of oversupply of our domiciliary care for both our self-funders and others. So we've got that market now really stable. But how long it lasts for, we're keeping an eye on it.
Thank you.
Henry and then Mike.
Thank you. I want to say how well I think the budget is going in the first 3 months after looking at last year's budget in depth at the other scrutiny committee meeting. I also want to thank your Brinton Way colleagues for dealing with two ladies in my constituency ward division, sorry, the right word, where you have really, really helped out. Thank you.
Mike.
Yeah, and echo what Henry said. I was going to make a similar comment. Interestingly, it's a year and 4 months since I was last involved with adult social care when I was associate lead member for the year running up to then, and the amazing improvements that you've made for the team, both of you, I'm sure, with Sarah's and Dean's leadership as well, but just really, really reassuring to see the progress, particularly on things like getting people with assessments done in time and so on. Question I wanted to ask is actually similar to Sue's one, really, except on a different aspect of what the government has changed, which is that the government has now scrapped the ceiling and all of those arrangements that were due to come in October 23, then were postponed for 2 years. Again, very difficult at this stage to assess the consequences, but they're going to be adverse, aren't they?
I think it would be more adverse if they'd come in and didn't give us any money to do it. That's the challenge for us. So I think that's why they've had to scrap it, because there isn't any money in the coffers to be able to deliver. However, from a national perspective and from an ADAS perspective, we're working really closely with our new minister, so Stephen Kinnock is working with us, and we're linking really closely to explain what it needs to look like. They are looking at a cross-party. It's never going to happen quickly, isn't it? Whatever changes we change for social care isn't going to be quick. We knew in the manifesto for Labour that actually they said it'll be if they're getting in their second term, it won't be until their second term that they change the policies and processes. We're working with them at the moment to think through what do we need short term. Is there anything they can do short term this year
whilst we manage the next 2 or 3 years. But I'm expecting to see a 1-year budget this year and maybe a 2-year budget the year after. But let's wait and see.
Eric.
If I could just add to that, we'd all love free social care. We love free social care. Look what's happened in Scotland. They're virtually bankrupt. And that's one of the factors. I'm sure it is. It just is too expensive for the government to pay for in the way we're taxed at the moment. It just isn't going to work. So, like I say, we all love that. I'm really grateful for our team in a way that they've dropped this commitment to come in next October, because we weren't going to, previously we weren't going to be given any more money. We weren't given any more money after the free cost of care or the fair cost of care came in and the changes were made to the fees we pay to care homes and to our care workers. And we'd love all these things to be free. We'd love people not to have to use their resources, but somebody's going to have to really think outside the box to find a way of doing that. I think printing money isn't the answer.
Any more questions before I unleash myself? Firstly, just remember that, sorry, Sue, let's unleash you.
Sorry, Graham, I know you were looking to close. It's just a thought, based on what Sarah was saying, but we've seen significant increases in public sector pay for junior doctor settlement, non-trained drivers, 5.5% for public sector workers. What impact is that going to have on our budgets, and will there be any sort of support for that? Because that's going to significantly increase our own costs of care, surely.
So what we haven't done at the moment is looked at the fair cost of care, the living wage.
Yeah.
We're waiting for that to come out. So the living wage has an effect because the majority of our spend is on our market. So depending on what the living wage is, and I absolutely agree with paying the right money for this care sector. No doubt about that. So good if we get a good living wage. However, to fund that is really important. So we know that this year, the rise in living wage cost us about 6 million. Yeah, that's 6 million to deliver, and that'll continue. So we know we have to put it up because it's 75% of most of our fee rate is going on the living wage. So that's an issue for us. So let's wait and see what it looks like next year. I've had rough bits coming in, but we really don't know the answer to that yet.
Thank you.
It's a bit of indulgence. I think if you look at the numbers, you'd find that, the National 1948 National Assistance Act about healthcare being free was a bit of a lie, and that in fact the health needs of many older people and younger people, but I'm thinking this afternoon of older people, without self-funders, you would not be sat in this room discussing a budget. If all the self-funders tomorrow stop self-funding, this council ceases to be. It's as simple as that. And self-funders are considered to be an issue when we have to pick up the tab. But without their spending in advance, we'd have to pay a lot more. And definitely the thing I didn't want to do when I owned my home was cross-subsidy. And today we're having to do cross-subsidy. We have to charge our self-funders more because Somerset Council is as generous as a mean authority can be. They work really, really hard on every blooming penny, I tell you. The staff work incredibly hard. And we're seeing in these papers the effects of every one of those interactions with homes and with people within the community. And it's been tough. What we're actually seeing is a managed budget for the first time, not just because it's big enough, but because it's properly being managed this time. And sometimes you have to be facing an iceberg to realise how bad it is. My other point is, when you come to work out next year's thing, do not expect the trend on the cost of nursing and residential beds to remain as it is. It will go up, because whenever you suppress anything within the market, there is a point when it has to come back up. So we're having the benefit now that is not sustainable. So as members, just be aware next year, when the demand is this and we need extra for this, that will be because that is the effect of holding it back today. You're enjoying the savings today, which you'll have to pay for next year. That's just business, and that's coming. I just wanted to ask you a question. In those groups, could somebody perhaps later send me the actual numbers of individual people, I was interested in to see how much an average person in each of those groups actually costs the authority. Because we've got comparable, but that's in artificial groups, but I'm quite happy to receive that. In fact, I'm sure members, would be interested to know how many in each of those groups it actually means in real people and how much the average person costs per sector.
We can probably give you this is down to per person, but it fluctuates. So each month we look at how many new people came in. So if I take this month as an example, month 4 into resident, I think we've had an additional 32 or
39.
39, there we go, 39 people come in to our service. So what we have to take off is those that leave the service and those that come in. So it's about another 39. So you add that in month on month. We're often just about averaging. It depends on, it's summer, so you don't get as many deaths. So you get more deaths during the year, so we fluctuate that. But we've got that data. We know roughly how many people are in and out. But when I tell you on tomorrow, it's not going to be the same at the end of the month. Okay, so but we'll give you a rough. And we know what's probably more important to you is the average price. So what we're paying in terms of, and it's easier to do an average price in older people's services. It's not easy to do an average price in learning disability services. So don't take the number and just split it, because it is very specific on what we supply for people with learning disability services, but we can do that for you.
Thank you very much. And then in a very timely manner, we know, I mean, I don't think I need to sum up with the report was clear. Great work being done, but unless I've forgotten, it's August. And there's an awful lot of the year to go, and winter cometh. So I'd love to see the projections work out, but there's still a lot more work to do. So, but thank you for everything you do for the people of Somerset. The crime and disorder overview report, which I was asked to put on later so that a certain councillor Sheary could actually be in the room. At least as if I had that level of control that she walked in the door when the item came up. So, thank you. Heather, do you want to say anything before Lucy presents? As I let Sarah do before her. You don't have to.
No, more than happy to. That's absolutely fine. I'm only going to say a couple of words. I promise I won't prolong it, because I really appreciate you letting us move the agenda around. It's much appreciated. Just to say that, as you can see in the report, that this is the first time really that this crime and disorder review, if you like, has come to us as Somerset Council as a new unitary authority. And we have an obligation to have it scrutinised by the council, which I think is really important. And we thought that the adult and health scrutiny was the best place for it to come to, which is why it's here today. Obviously, you may all take a view as that this isn't the best place, and we're more than happy to hear what you think about that. So what Lucy's going to take you through is there's a presentation that explains all of our responsibilities as a council with regard to, well, everything crime and disorder in its widest sense. There are more statutory responsibilities than I ever thought when I first got involved with the Safer Somerset Partnership back in 2019. So we've got a small presentation to go through, and there's also the annual report that we put together again, as we do every year. As chair of the Safer Somerset Partnership, I always have words at the beginning and words at the end. But the most important thing is the bits in the middle that Lucy writes and guides us through. So that's all I really want to say, unless Lucy has more things to say. But I just wanted to bring it to you, and I hope you all had a lovely time reading it. There won't be a quiz after, I promise, unless you're all very naughty.
Thank you. I'd just like to add, I also have a colleague, Claire Stewart, who's she's there somewhere, listening in intently. So Claire is my health promotion manager for serious violence. There's a lot of interventions that are out on the ground that I'm not close enough to the details. So Claire's here today, help me if there are any questions on serious youth violence. And we will cover some of it, and there are some case studies and all sorts. So Claire's here in case you want to go down that road. So thanks, Claire. So I assume I can just share my screen. Is that how we're working? Okay.
You're fine unless you need my help on all this stuff. Yep.
Okay, so everybody, so as Heather said, we do have a statutory responsibility to hold an annual overview and scrutiny committee for crime disorder under the Police and Justice Act 2006. So that's one of our statutory responsibilities. The role of this committee is to not just look at what the council does, but what the partnership does. We normally would have fees from the Police and Crime Commissioner here invited as well. I understand they couldn't make it today, which is unfortunate. We do try to plan this ahead of time. There are, as you know, a raft of agencies that are statutory in terms of crime and disorder. We have probation, the ICB, fire, the local authorities, obviously, and we also have, the ICB. And the Police and Crime Commissioners that have a duty to participate as well, even though they're not statutory. And beyond that, we have BCFE sector as well that have a huge role to play in assisting us with out on the ground work. So there's a huge amount of people that are involved in this agenda. And to be honest, I could probably spend a whole item just on one part of this agenda. So we're trying to bring it all in together. So I apologise for the briefness or the brevity of a lot of the things that we'll talk about. One of the recommendations of the report is to consider how you'd like this to be done in the future. So if there is a particular aspect, a particular theme that you want us to really concentrate on next time, we can look at that as well. So, the purpose of this one really is to give you the overview as to what we do. So I'll talk about what we do in the council, and we'll talk about what we do in partnership as well. So during the session, we'll look at, as I say, what community safety is actually, because some people may not know. Quite often people misinterpret the meaning for health and safety. I often get really random queries about fire and exit points and all sorts of things, because it all it sounds the same, but it's not. We can talk about the prevalence and we'll talk about the duties. As I said before, we'll talk about the partnership, and then we'll look at some key activities. You do have the annual report. The annual report has yet to be ratified, hasn't it, by the Community Safety Partnership. What we normally do is kind of go through that. I've picked out the highlights and put it into the presentation for you anyway, so I'm not going to go through that. We'll look at the risks and challenges because there's so many statutory responsibilities. There are risks and challenges associated with all of the work that we do. Some of it is very difficult for some people to hear as well. So if there's anything that I say that triggers any emotions for anybody, do feel free to leave the room. We will talk about domestic abuse, we'll talk about sexual violence. So things like that are emotive, so do look after yourselves. And then we'll look at what we're going to do. So the annual report, I should say, looks at the previous year. So some of you may have questions about things that aren't related to that. If you have questions, we'll also talk about what we're doing now. Questions we'll pick up because we'll look at across in this presentation. We won't just look at the past, we'll look at the future. Okay, so what is community safety? So as I say, it does get misinterpreted a lot. In terms of statutory responsibilities, we'll go on to that in a moment, but it picks up a lot of these themes, but generally we work thematically. So my team, there's a number of people in my team and they all look at particular bits of the agenda. What I would also say is that the agenda changes all the time. I've been doing this job for about 20 years, and the reason why I've been doing it for this long is because it's changing all the time, so it keeps my interest. The things that we are prioritising now, we didn't generally look at 5 years ago. It changes all the time. Things that are in the news, if there's a particularly high interest item in the media, will spark a community response, will start a protest, will start changing legislation, which then changes the agenda. So things like the Sarah Everard case, or Borg, Violence Against Women and Girls, up the agenda. The recent stabbings in Stockport have started protests. My whole last week was taken up by doing that work, which is, unprecedented. So our work changes and it shifts all the time. Okay, so in terms of prevalence, we look at it on a daily basis. One of the things that I was going to talk about in our activities is that we now invest in North Somerset's data team because they have direct access to police systems there. So we invest in their capacity. They've got staff that look at our data as well as their own. They also look at Baines and South Gloss. So we have a really good partnership arrangement with them. And every month they give us a whole new dashboard about what we're looking by crime, so we can consider any trends, any patterns, any sudden influxes in types of crime. And that helps give us an overview about where we should be directing our attention, where we should be directing our resource. But the bar chart there on the screen just shows you all crime. It's a relatively stable picture. We haven't seen any huge spikes in any particular types of crime, but that darker blue colour at the top, that's serious violence. So, and you'll find across the country, most crime is made up of reports from the police of serious violence. And the reason why that is because it's a huge amount of crime categories all in one. So that will range from domestic abuse, and most of you will be aware that domestic abuse is the predominant crime reported in Somerset and nationally. It includes everything from that to homicides to harassment. I can't find the word now. Knife crime, everything. But it's there's no way of breaking that down. So it's always in serious violence. But there's a whole agenda on that we'll talk about in a moment. When we look at crime, I should add as well, is that there are different ways of looking at it in terms of who we compare ourselves to. So we work as a community safety partnership, and there are ways that we can compare a community safety partnership to similar community safety partnerships across the country. I'm not able to share that data, but I've got it, so I can talk about that. We can also compare ourselves to the other neighbouring authorities in the Forth area as well, which we do all the time. Generally, what you'll find is that Somerset is second to Bristol for everything. So it would always go Bristol, Somerset, and then it will be Baines and South Gloss and North Somerset. And it's because of the size of our population. So you'll always see that trend. And Bristol is just it's a bit different because it's a city. It's got very different population makeup to everybody else. But when we look at funding, which I'll talk about later as well, the funding that we get from the Police and Crime Commissioner is based on a formula which is against a population crime rate. So that works in our favour because, again, second to Bristol, we get the biggest pot, which is always to our advantage. So in terms of statutory responsibilities, there's a whole raft, and as I say, because the agenda always changes, so does legislation. It comes very quickly and quite suddenly. So an example of that is the Counter-Terrorism and Security Act in 2015. It brought so much work with it for the council, and it came very, very quickly as a result of national priorities and national strategy. And also the Domestic Abuse Act 2021.
Lucy, could you just move your microphone a little bit nearer to you, because you're fascinating, but you are sounding like a long way away.
I'll move it towards it. I do sit back when I talk. So yes, Domestic Abuse Act 2021 changed my whole team, how we worked, what we needed to do. And it does come with funding sometimes, it doesn't always. What I'll talk you through are kind of our main functions and what's funded and what's not. So the main responsibilities for the council is around generally community safety. We have to do a needs assessment on a 3-year basis. We have to have a strategy. We have to have a community safety partnership. We have to do overview and scrutiny. We're also responsible for reducing reoffending, which a lot of people don't realise, which includes first-time entrants. So we have a relationship with the Youth Justice Partnership. I sit on there, and they sit on the Community Safety Partnership, and we look at how we can create a more interlinked strategy to make sure that we're all working together. In terms of antisocial behaviour, some of you will be aware from if you've been involved in district council, when we moved into a single authority, along came with it our responsibilities responsibilities around antisocial behaviour. And the main responsibility for us is around ASB case reviews, which used to be called community triggers. So, which is essentially if a victim of antisocial behaviour reported to the police or any agency actually that's statutory a number of times in 6 months and didn't get the response they wanted, they can raise, it's almost like a complaints procedure, but you have to create a very quick time multi-agency response. And we're now as a council are responsible for those alongside our police colleagues. Counter-terrorism, as I said, we are a statutory partner for the prevent duty. So in my role, I'm a designated named officer, lead prevent with Somerset. So I coordinate all of the strategic activities for that. So that is how we prevent vulnerable people who are susceptible to being radicalised in the community. And to do that, we use a channel process, which is again statutory. It's like a multi-agency panel, which I chair, and we consider children and adults who may come to the attention of the authorities because of their behaviours and their vulnerabilities. And what we do is risk assessment and planning around those people in terms of their engagement in, it might be particular rhetoric, religion, it might be an online group, and we assess their risk and then we put plans in place to stop them entering into what we call the criminal space. Once it goes to that criminal space, it then goes up into the police space. But the council is responsible for that. So should, hasn't happened yet in Somerset, but should a terrorist attack happen, the first thing we would do is look at, was that person known to us, and prevent, because our role is to stop them getting to anywhere near a level of where they would carry out an offence. So that's a big responsibility. Domestic abuse, we are responsible for commissioning specific services, and we have to provide services for everybody who experiences or witnesses domestic abuse, full stop, which is huge. That's a big change. It's very vague as well. So we have very specific service elements that we have to provide for everybody in our community should they require it. That includes children, and it includes counselling services as well. So one of the big changes we've made over the last couple of years is that we've commissioned counselling services for children and adults that have or have experienced domestic abuse. The big change of that legislation as well is that it creates a legal status for children who experience domestic abuse in the home. It makes them victims in their own right. So they're not just dependents of victims, they are victims in their own right, and we have to provide them with service. And lastly, the serious violence duty. So that's the newest one, and that came out last year. So that provides the partnership, so the community safety partnership, with a responsibility to share information and work together to reduce serious violence. And then we have to focus on children and serious youth violence. So the way that we do all of this work, because everything that we talk about, we can't do on our own. Even though we've got responsibilities, we can't resolve these issues alone. And it links to so many different partnerships. And as we've seen from the conversation with the SDAS guys, their agenda completely interlinks with this one. So when we're talking about county lines, when we're talking about drugs disruption, when we're talking about exploitation of children and criminal exploitation, drugs are involved, crimes are involved, and children are involved. So it links across all of our agendas. So the partnership landscape around this is huge. So the structures chart that you've got there just shows you where all of those links are. And there are subgroups to the Somerset Partnership, and they do change. They generally follow where our statutory responsibilities in the main lie. I think that the HACOM community cohesion one is the only one that isn't statutory, but it's the right thing to do. And particularly in this climate, as we are at the moment, that partnership forum and the networks that we've developed with that group have suddenly just come to the fore, and it's really shown its strength in the last week or so. So how do we fund? So everything in community safety is grant funded. So all of my team and myself are all grant funded. There's no investment from the council anymore. It's changed over the years. So we have the biggest investment is what was DLUC. It's now back to MHCLG, I think. So we have a significant grant for domestic abuse services, and that's because of the commissioning responsibilities that I've mentioned just now. We have to provide very specific types of service, which cost a lot of money. So we have an integrated contract, 5-year contract for domestic abuse, that is an overarching contract with all of the service elements that are required. And that amounts to more than the 1.2 million that we get each year. When I say that the council doesn't invest, it invests a little bit, and what they do invest in is that contract. So the other grants, we have a serious violent grant, which again is new burdens funding because of the statutory responsibilities. We have a police and crime grant, which is an annual grant from the Police and Crime Commissioner. We have additional one-off funds for IDVAs, which is Independent Domestic Violence Advocates, which is again put into the domestic abuse contract. We have small amounts as well that are one-offs. We have Safer Streets Fund, which is a national programme that we've just been given a very small amount, like £30,000 for this year, and that's work around violence against women and girls. And we have some one-off money around youth violence and exploitation as well this year as well. So I'll just show you examples of what we do. I've already talked about the domestic abuse and where that money goes. The Police and Crime Grant funds permission services that follow the community safety strategy. So our priorities in the strategy are around reoffending, domestic abuse, but also we use that money for the function of the partnership. So it funds some of our staff, it funds the comms work that we do, because a lot of the work that we do is about raising awareness in the community. So we use that money for comms. And we also assist some of our partner agencies who are struggling. So a good example of that is Somerset sexual assaults and rape. SARSAS. I'm trying to do the whole thing so I get it every time. SARSAS. So they currently are holding a huge waiting list for counselling for victims of sexual violence. So we're supporting them at the moment to plug some of that gap, because the prevalence of sexual violence, and with the increased awareness around violence against women and girls, it's very likely that what follows is more reporting and less tolerance. So we're absolutely expecting that to happen, but it's just happened very suddenly. So we're assisting them with some of that grant. The violent crime, serious violence grants go towards, again, comms, because we need to communicate with our residents about what we're doing, and it's that reassurance piece which is so important. We do spot purchasing for schools. We put training into schools, and it links back to what we talked about earlier about drugs and alcohol. We do work with drugs and alcohol partnership as well, and we funded drugs and alcohol navigators in hospitals as well. So when people pick up at A&E with injuries that are most likely to be around a bladed weapon, there's drug and alcohol use, that they a particular member of staff that can help them through that, ask them the right questions, and get them screened the right way. We have talked about safer streets, and we also on that budget. I won't go on to the DA one because we've done that. So some of you will be familiar with the knife aim that came to Somerset this year. So this is an example of a programme of work that links to our agenda. I should add that our culture team led on this project, and it was very much messaged around tolerance and a positive message around how we should be supporting our children. Things like this can be positive, but also can be negative, because what we need to balance is the links between, or the balance between raising awareness, but also not increasing fear or perception of risk. And what we've always found in Somerset is the prevalence of crime is low, or relatively low, and it always has maintained low, but the risk, the feeling of risk and the perception of risk and the perception of victimisation is really high. And it's very much related to the fact that we have a growing older population and our elderly residents really feel fearful. But actually, their risk of being a victim is really low. What we need to worry about are our children who think they're invincible and just do all sorts of things. So it's that balancing act where we put our comms out. But that's what we'll do. We'll focus on particular people in our community. But then when we look at domestic abuse post-COVID, we had a huge influx of more elderly residents coming forward of being victims of domestic abuse. So it always does change, and we just have to keep an eye on who in our population we need to target. We also did a town centre youth safety plan. So that's part of some interventions that we did, targeting, I think it was Bridgewater and Taunton, and we engaged schools. And it's just getting out there and actually talking to children, saying, how do you feel? What are you seeing? How does it feel in the town centre? And the purpose of that was that there was some research done around where are hotspots around serious youth violence, and those were the two main areas. So some resource went in there, and we did a survey of children, young people in those areas, and the response was huge. They had a massive amount of children come forward and give some information about how they felt and where they felt problems were and how they felt we could help. So that was really good. And if there's any questions on any of that, Claire's got the information. And also we support SASP. So across our agendas and across our work streams and across partnerships, actually, we support SASP, which is Somerset Activity and Sports Partnership. And the reason why we use them is because the work they do to divert children from criminal justice, even from right at the early help stage, before children get involved in antisocial behaviour, they can start to get them interested in things at that early age, get them into peer groups, get them into different types of sports that they didn't know existed even, and it really does help change them. But they also intervene with children in a more targeted way who come to our attention. So again, divert them, give them a purpose, get them out of their homes. And it does prove really successful. We've got some really good case studies like LJ's, and we've also got a really good evaluation report that SASP have done around their diversion activities for young people. So in terms of challenges and risks, so what we've just talked about, and some of that stuff was kind of what we've done in the last 12 months, and the challenges and risks bring us into the here and now. So in terms of our challenges we have at the moment is around, one of them is around One Team. So some of you may know One Team working. It's been around for quite a long time. When we moved into the single council, we had to kind of look at it in a whole and say, well, in the round, and say, well, what are One Teams doing now? How do they work, and where do they sit in our system? Are they safeguarding? Are they community safety? And how do they work? What we found is actually they all work very, very differently. They've all got different strengths and weaknesses. But because they are all different, depending on where you live, you might have a very different response. So we're looking at actually how do we most effectively use that resource and that capacity, and how does it link to what we now have in our system, which is community connect workers. We've got LCNs, we've got things that didn't exist and One Teams were set up. So we're going to review those. So that's going to happen in the next few months. And the other challenge is kind of related, which is around antisocial behaviour work. So again, when we moved into a new single authority, the functions that were in the district council around antisocial behaviour and how we work with our communities and how we stop things escalating is very different wherever we were in Somerset. And our partners in the police were very clear that they felt it a real challenge because depending on where the antisocial behaviour was, they had a very different response from the council. So we're looking to change that. We're looking to really get to grips with our responsibilities, but also how we work in partnership to get that right. So that's also going to happen over the next few months. So looking to the future, there's new statutory responsibilities coming again. So the, some of you will be familiar, some not, with domestic homicide reviews. Domestic homicide reviews are the responsibility ultimately of so the Community Safety Partnership are responsible for reviewing a death of anybody over the age of 16, where it is likely or suspected that they've died as a result of domestic abuse. So when we are notified of a death, it comes through to us. We then share it with Heather. We look at set criteria, and if a death meets that criteria, we must commission a review. It's a huge piece of work. It's changed the way my team function because it takes a lot of time and it's very, very expensive. The government have revised the duty guidance around that, and what we're looking at it's currently under consultation, but what we're seeing so far would increase the amount of work that we already do around domestic homicide. So we're kind of on tender hooks with that one. And the cost of each DHR is around £10,000. We have to commission an independent chair for each one. And we're currently on the 64th notification since we started doing DHRs, which is really high. That's not to say we reviewed each one, but we've reviewed most. And they can take years. So you could commission, we've got one that we started about 3 years ago that's still ongoing because it depends on how, there's lots of factors. For instance, how committed the friends and family are to the review can really impact on the time frame. Yeah. So, and also if it's a criminal investigation, you have to wait for the court case to conclude. So there's lots of variables there, but it's a huge piece of work. I could probably spend a day with you talking to you just about domestic homicide reviews. That they're a real challenge for us, but something we have to do. But also, the whole point of them is to learn lessons, to stop deaths happening in the first place. So as a partnership, we really need to focus on how we do that, but also in relation to other reviews that we do. There are a number of reviews that we do that are combined with SARS, with adult reviews. Or children's reviews. So it's how do we learn the lessons from all of these reviews that we do together as partnerships and committee. Needs assessment and planning. There are a number of statutory needs assessments that we have to undertake this year. Again, it's a resource and capacity issue. So it's just to make you aware of those. So for this year, we have to do a community safety one, domestic abuse, and serious violence all in the same year. So I mentioned right at the start that we invest in North Somerset's team, so they're doing a lot of the data work for us, which is great. But we still have to draw that into an assessment, and then we also need to write strategies and also have to have those signed off. So there's a lot of work just on that thing. Prevent training. So the prevent. Some of you would have heard of RAP. You may have done RAP actually. Most people would have had to do RAP. Which was a workshop to raise the awareness of prevent. They were decommissioned as face-to-face training programs a few years ago now by the Home Office, and a new one's just been commissioned. So it's currently being trialled, but once that new program comes online, we must train every relevant member of staff in the organisation, but also in every educational establishment. And our other statutory partners also have to do the same thing. So it's a huge undertaking. What the good thing is that this time, although they call it face-to-face, we can do it virtually. So it won't be as hard as last time because Tom, who spoke earlier, was our RAP trainer, and he would probably go completely grey if I told him he'd have to start doing that again. So, that's that one. And then the final one is serious violence. So serious violence, if there is an emergency response, if there is a critical incident in Somerset, there is a clear process that we know about. There's a silver process, there's a gold process, and there's an emergency response. With serious violence, it's actually very similar to what's happened in the last week, where we have had a national incident that's created a local problem for us. So I'm talking about the Stockport incident that then resulted in a number of unrests and violence across the country. Somerset, we've been working on it for the last week with our police colleagues and partners. It's never hit an emergency response, but the level of fear in the community, the amount of work and capacity it's taken for myself, my colleagues, the police, to calm the community, our staff, people that work in the asylum hotels, members, it's taken so much time. And the problem is that it doesn't fit within our emergency response, but it is an emergency for everybody, socially, and kind of the way that we work and emotionally, it is for everybody. It feels like an emergency. And it's the same with a serious incident. If a child died from a knife incident in one of our town centres, that would be the same response. People would be fearful and they would look to us, the council, for a response. So what we've been doing actually for the last few months is working on a non-critical incident response protocol. And we've actually been working on that, and I've applied it for this current situation that we've been dealing with the unrests in Somerset. So the two things have come together. So it's been quite a timely process to go through because we've almost tested that model for a different type of response. So that's something that we're working on. So the critical incident response, the serious violence, the youth violence, I should say, is following an Enabling Somerset model as well, because we're, apart from North Somerset, we're the only local authority in the course area that hasn't had a child death as a result of a knife incident. It will come. It will come. So we want to be ahead of the curve and make sure that we're able to just respond. And actually, the key issue with it is it's not about what we're doing back office, it's the comms. That's the real bit to get right, is how do we communicate with our communities when something like that happens. So moving on to the JTI, I think there's obviously the Children's Committee has had a focus item on the JTI inspection, so that's a joint targeted inspection, which is on serious youth violence. I thought I'd bring it today just to make you aware that this partnership, the Community Safety Partnership, is involved in that, in the delivery of the strategy that's coming out of that inspection. So the main things for us is that the main criticisms for us was the governance structure across the strategic partnerships. The way that we communicate around serious youth violence across strategic partnerships was an issue. And what they said to us was, strategically, you don't know what you don't know, and you should know. You should know where your gaps are. You should know where your focus, where your target, where your kids that you really should be focused on. You should all know. It's not good enough for just knowing in pockets. So that's something we're working on. How we use intelligence. I think Lisa touched on it earlier about the inspection they've had. With the JTI, it's about how they share intelligence, and the police have certain criteria about sharing intelligence. But it's in terms of the serious youth violence and how they share information with children's social care, it was found that it was quite lacking in terms of when they share information, what they share. We have to do a strategic needs assessment and a strategy, and unfortunately, when they came to visit us, we haven't. But it's something we have to do every year. We just haven't done it at the time, so that has to be done. And then evaluating what we do to make sure that what we do with our young people actually works, and that we can evidence that. So that's very, very, very quick of the agenda.
Did you want to say something there?
I think just to say that I had alluded to it at the beginning when I first got involved with the Safe Somerset Partnership, which is it's the crucible for all of these statutory duties. It was really amazing to me how many statutory duties we had. We were still in the kind of 4 districts and 1 county, so it made sense to have one area look after it all. But equally, it's just really important. So that's all I want to say. Really, was all of these things are important, and we just keep getting extra things piled on. I think what's not clear is that it might have been alluded to by, or you might infer what Lucy said, there's some huge team that's behind all of this in the council. It's not really that big, and they deliver quite a lot, an awful lot actually, with a very small resource. But we have to get everything done with and through our partners, over whom we have no control, but just influence.
Sounds familiar. Sue and then Martin.
Okay.
Thank you, Graham. I must admit, when I started to do this, I thought, oh my God, where do you go from here? It's certainly very complex. I'm pretty certain, Heather, I suspect it's one of those things where there are occasions when you wish, if I had known what this was going to involve, I might have just said no, because it's massive. And in terms of keeping it, how do you account for it all, where the accountability lies? And with the addition of all the extra duties that are coming on, all the things you've got to produce, the strategies, the tasks, the targets, the reviews, do you get any extra funding come along to help you to deliver those and cover the cost of the extra staff time that's required? In terms of how we deal with this as a scrutiny panel, I don't think an hour or just a session in one scrutiny committee on an annual basis is sufficient, because this is massive and there's a lot to get to grips with and understand. And it's whether we look at, and some of this goes into children's, and I think there's an element of this came to the last children's scrutiny, didn't it, which I think was relating to the children's side of it rather than this. And I just wonder whether there is a case that because adults and children in some cases link, because parents influence children, as we found out, as we heard from the last item, is whether we actually look at having a dedicated scrutiny session, both children and adults, so we can actually get under this and get a far better understanding of it. Because, as I say, this is just the tip of the iceberg, and for me, I'd like to know more about it. I feel I don't know anywhere near enough. It's something that's going to become even more important as time goes on and tensions do start to rise, for whatever reason. And, for me, it does feel as though one way ahead in terms of how we deal with this, if we have got a statutory scrutiny requirement for it, is that we actually do a joint children and adults, and we actually have a whole scrutiny meeting dedicated to it. And then perhaps from that, we can look into some of the more specific elements, but it also needs direction from you, Heather, as well, as chairman of this, is what are you actually looking at us as a scrutiny committee to do to actually help you to deliver some of this stuff?
Thanks very much. No, absolutely right. I mean, the first thing I really want everyone to do is understand what it is and the complexity of it and how important it is. Some things I was jotting down as you were speaking, Sue, include things I wanted to let you know and assure you. Some of it's about assurance as well, that the officers, small in numbers they are pretty good at managing both very good evaluation of the projects that we have, very good risk analysis and some of the progress, they're tracked really well. And that's the kind of thing in the scrutiny with more time we could take you through, and you can make sure they are as robust as I think they are. I think that's important. I think the bits that are coming up as challenges are really important for people in the room. Partly, I think antisocial behaviour, actually understanding what it is, what it's not, what our council responds to it, and its prevention of antisocial behaviour is so important. And I think that would be great to have everyone's help with that, or with the old community trigger type things as well, very important. We've got the mechanics of that community trigger, we've got the mechanics of one team, but I think actually getting a proper approach to understanding what antisocial behaviour is and isn't, and who picks it up is really important. And I think the only other thing two things I should say really quickly is Lucy is working on an all-age exploitation strategy, which I think is really important. I think that's where this children's and adults comes in. It's very important. And I think the other challenge really is that as an adults and health scrutiny, you are very bothered. I know you are about the integrated care system. You're very bothered about our partners in this space. You're very bothered about prevention of all kinds of early health and intervention. So again, we need all those same partnerships to work. So if I sit there, I don't know, I've signed off on too many DHRs, the domestic homicide reviews. And that's a tragedy. Everyone's a tragedy. I'm the kind of guardian of the process and the system. You know, other people look after the people. I'm about the process. And the thing that always upsets me, and I think it might be in SARS as well, in any of the safeguarding efforts that we go to, there's many of them. We work out all the learning, but it's really hard to make sure the learning is actually acted on. So yeah, as you say the same things time and time again, and it's that bit where we're all crashing through trying to keep it all done statutorily. It's how we're holding ourselves and our parts to account. So those would be that's my answer to that one.
Thank you.
Did you want me to come back and
I don't think there is any need to come back on, but I think if there are specifics, then it would be helpful for you guys to maybe come back to look further into some of these issues. But again, to me, looking at the complexity, what is the risk of things in effect falling through the cracks, or the risk where one body can pass a problem or an issue onto another and things start going round in circles. So there's an awful lot of activity going on, but not a lot gets delivered because all you're doing is passing on from one to another to another.
Okay, Martin, and then it'll be John Bailey online.
Thank you very much. Interesting. I just had a flash up of an email on our council league, and there's warning from I think it was the officer who was talking to us of disturbances scheduled on Saturday in Taunton. Just come out as we're on this subject. It's interesting that it's just appeared, but that wasn't what I was going to talk about. Sorry, Joe. Yeah, it's a bit deja vu-ish, this, in some respects, because Heather and I, or Heather chairs it, and I just sit there. A lot of all these different boards and panels and partnerships all come up on the Police Crime Commissioners panel regularly. And rather like Sue was saying, I've always had trouble linking them up and seeing that they're not working in silos, as you say. And I'm a bit have difficulty because I understand this has got to come to us today as a statutory thing. And really, I don't think we can do justice to it, frankly. It's a huge subject with you could talk for hours about one of the particular bodies which are there. So it's a bit disappointing that it has to be dealt with. I understand the difficulty, it's got to be done, and so we will no doubt deal with it today in the way we have to. But I agree with Sue. I think we're going to have this, if it can come to this board, we need much more detail on this to be properly scrutinise it. And as I say, it is very difficult, and I found it difficult on the police panel, and as I've said on a few occasions there, and I'm finding it difficult today to say how we've actually dealt with this. And the work going on is tremendous, but we can't really see it. That's my point, Chairman. And yes, it's interesting what you were saying about disturbances. I read in the paper today, of course, that was a judge somewhere said it's about time we started calling these riots. But that is a difficult one, I know, because from my background, I was on occasions when a riot act was actually read. And once you read the riot act, you then have the public purse involved for any damage that caused. And that's why they won't read the riot act. But anyway, sorry, that's an aside. Thank you, Chairman. I wandered a bit there.
An enjoyable meander.
Okay, well,
I thought we were going to get onto the rights in Yeovil then.
No, I'm more into the riots in Brixton, places like that. That was a long while ago.
Different memory.
Yeah.
Right. We're going to go to John Bailey online.
Thank you, Chair. Can you hear me?
Certainly can.
Okay, thank you very much. I'm going to sort of just touch on the integration situation, but I'm going to be focusing on a very local level because I think that's where we need to see this integration actually having an impact. And I'll make a couple of comments and then just have a question, really. I've been involved with a number of youth groups, both in and around the Martock division. since the previous administration pulled out of any support for youth work. And this was set up, it's been volunteer led, and I think it's 13 years we've been doing it now, one way or another. And I'd just like to thank the police for their support, the PCSOs. And again, there were 7 when we started. There are about 2.5 or maybe 1.5 now, who are really supportive to the youth groups and come in as regularly as they can do to actually relate to the ground support. So we are seeing a very integrated support, and I'm talking about antisocial behaviour here. And part of our brief is to avoid these young people getting into the criminal network and onto a criminal, if you like, what am I talking about? Any sort of record. That's what I was talking about. The question I have is that where do we now go for stats at a parish level on antisocial behaviour? And I wonder if I'm more than happy for someone to reply to that offline, if they like, but that was the question I had. But the first 2 comments were about the thanks for the support that we get.
Thank you, John. Lucy.
Yeah, thank you. So it's interesting. The local authority has a responsibility to record and share information on antisocial behaviour to the government. The police also have stats as well. When we ask, because of the way that we work in Somerset now, it's really only the police that are dealing with antisocial behaviour. We, as a council, we deal with bits. We deal with statutory antisocial behaviour, which is like noise abatement and fire-tipping and graffiti removal, that sort of thing. But in terms of civil disruption, youth groups, and things like that, really it's the police that do the majority of that. So in terms of data, they hold it. So if Councillor Bailey wants to talk to me, I can see what I can get. I get data from, I don't think Lisa's on there, is she? But I work quite closely with her team. So the antisocial behaviour manager, it's called Cohen in police bar area. He manages both the east of Somerset and the west of Somerset, and he has the data. So we can break it down from that. But there's no kind of, one of the things that we're looking at is how do we better report and publicise what we're doing, because it's one of the reasons working.
Okay, thanks. So I should drop you an email about the parish level stats, basically, Lucy. Then your a county email.
Yes.
Okay. Thank you.
Yes, it is.
Thanks very much, Chair.
Thank you, John. Henry Bruce.
Thank you, Chair. My question is, thanks for the presentation, first off, there's so much useful information in there. The one teams, it's about their presence in communities. I know you said that the review needs to be undertaken. I've had some concerns raised. My ward is one of the ones that was the Together team for Sedgemoor, now the one team. Did have a presence in the community centre. They've now withdrawn. They don't have that base there anymore. And there is a perception from the community that they might be neglected, or the folks might move away from the community because they're not based there anymore. So I would urge to get more information about that review of the one teams and where it's going, because there's not much information coming out at all. And I would call for stronger engagement of councillors in that review, in that process, and generally stronger engagement with councillors for each area in terms of the community safety information specific to that councillor's ward, because the more we're involved and engaged in that, the more we can help, and help also diffuse any concerns from the community, because we know what the situation is rather than hearsay that sometimes gets through. So that would be really helpful. So that's the first point. And that's both town and county level of councillors I'm talking about. And my second point was about the importance of reassuring communities of safety. I just wanted to ask a bit more about comms and how we are engaging with different communities better. I had a story raised to me in the last few days about a lady who was too scared to even go out and do her shopping because of fears raised by the recent scenes of unrest. And my question is, who would be best placed to help somebody like that, who's suffering from that kind of fear? Is there a way that somebody could talk to her, go to her, do something to help reassure her and how are we engaging with those particular, she comes from a particular community who's affected by that situation. And then I wanted to ask about generally in terms of how we deal with this topic in the future. I think I raised this last year that I thought it was a bit strange that we were seeing this topic come through to adults' health scrutiny. I think this is one of the prime examples of a topic that is something that covers both community and children's and adults' health, and is a subject that needs to be dealt with by a joint scrutiny committee where I don't know whether we can pull members from each of the scrutiny committees to have a joint scrutiny, but there are different subjects that are crossing these scrutiny committees, and I think they need to be dealt with as a joint rather than individual scrutiny.
Yeah.
Thank you.
Okay, thank you. So, first thing around one teams, yeah, absolutely. So the review will take place over the next few months because it's in line with the redesign of the council. They currently sit around different places, so I'm trying to bring it all together. I'm currently in talks with the current staff that work on one teams, because again they sit under different management at the moment, different places, but they soon won't. They'll all come in. And I think the key thing that I've been talking to them just yesterday about is actually when one teams when they were created, there was in each district area there was also a community safety function. And over the years, the community safety function died a death in some of the district councils, and one teams plugged it back, so they became different depending on their local area. So some one-team coordinators were just coordinating meetings, other coordinators were community safety officers. So we're now in a really good opportunity now to look at actually what is it that we need in our communities, because Councillor Bruce just mentioned about that local community. Is it what we need to look at is what is their need? Is it that they need meetings? Is it that they need a one team? Do they need a together team for that? Or is it something different? And we're now in a place where we can, with those staff, say, what is it that you were doing? How did it work? What can we do differently? How can we make best use of what we've got? So I'm bringing them in to my community safety team, basically, going forward. So they're not just isolated doing one team activity. So there's opportunities there, but absolutely we need to work together and make sure that members are aware of what we're trying to do, because it's one teams that communities see. And there's been years of no engagement with our communities, really, apart from one teams. So then that's what they know. So if we are going to look at using them in a different way, if we're going to call them something different, if we're going to reframe or rebadge it or rebrand it, we need to work with people so they understand that we're not removing something, we're making something fit for purpose. So that's the plan. So that's the one team bit. In terms of how we communicate, so I know which lady you're talking about. So in terms of reassurance for you, so while I was hid behind the pillar, I was working on that comms thing that you just see on.
Oh, great.
So we've been meeting with the community and voluntary sector leaders over the last couple of weeks, and that lady in particular was raised as a concern. So the answer to your question is we work with our community groups because there's networks out there, and I don't really want to call it a silver lining, but it's kind of a silver lining from what's happened in the last couple of weeks. Is all of our community leaders are suddenly engaging with us so much more than they were before, and we've got really good relationships happening and new relationships happening. So we've got people out there on the ground. We've got village agents, we've got voluntary sector organisations, we've got Somerset Community Council and Diversity Voice. We've got lots of people out there, but it's how do we harness it all in the right way? Because my team is 4 or 5 people, and we all do very different work, but we're not community engagement people. We are strategy writers and commissioners and things, so we'd be absolute rubbish at going out. I haven't done it for about 15 years. So, but our other people, like the one team coordinators, things are those people that know people and know how to get out there. So it's how do we make use of the people that can get out there in the most effective way. But for reassurance purposes, if somebody is struggling and there are pockets like that community that are really struggling at the moment, we know about it and we are planning around it. I think that was it for those two bits. The other bit was the.
Just for one tiny second, I was just going to say, I know most of the people in the room here, all councillors tend to be parish councillors and town councillors as well as Somerset councillors. And one of the things I was just going to share with you was that when I was kind of tapped on the shoulder to say, would you chair the safety partnership, the Somerset, Safer Somerset Partnership, I was asked and said, well, because, it doesn't have to be a councillor who's the chair of this group. It doesn't have to be somebody. It has been the police in the past. But actually, it was an outgoing police inspector who said it would be really good if it was you, not because of me, but because you're a councillor. And then that's that convening and that tapping it into the communities as well. So it's, I think that's really important. Certainly, I know Lucy's explained it, but I think that's really important that we do all, we can get those comms out that help you do your jobs locally, because actually you people on the ground know those people best. For support, obviously, but I think getting the right information out, managing expectations, helping people understand, because I think we've all experienced our local police officers being a bit thinner on the ground than they used to be. So some of the things that they've come to, they're not coming to anymore. So just as they were kind of on that one, but yeah, thank you. But you guys play a huge important role in it all.
Thank you. Can I just say, we've got 17 minutes till they turn the lights out. We've got 2 more speakers. I'm not getting locked in Bridgewater. I'm not having it. I've heard what goes on here. So we've got 2 speakers and we've got to deal with those recommendations. So I'm just going to allow those 2 speakers. I'm sorry, that's what we're doing. So Rosemary's next, and then it will be Henry, and then we'll deal with this, and that's it.
Hello, can you hear me?
Yes.
Yeah. Thank you for this, because when I saw this on the agenda, I was plowing my way through the agenda and I thought, what's this got to do with me? I'm into adults and health scrutiny. This didn't really fit with me. I must have missed it last year because I missed a lot last year. But I also welcome the fact, I went round with the previous Police and Crime Commissioner talking to people, and I found it fascinating to hear the way that people actually perceived what was going on in their communities. I didn't think you had a worry here, but obviously you have a worry. They had worries, and it was their worries that we were addressing. And also the PCSOs, not having so many of them, that has impacted on our community, because I knew who the 2 were that dealt with us, and they used to come past my house regularly. I used to tap into them. But those people have disappeared from us in a little way. So I'm happy to hear this. But, again, I thought, well, no, I'm scrutiny. I want to see what's happening so I can scrutinize it, exactly what's happening. And I think that's helped me understand by going through the papers. I'd read them, but, some of it goes there. I've read them, and I'm not going to let it go on anymore because I'm the one that wants to go. I'm sorry. But thank you for what you've said, and I hope that we can build on that. I don't see how we can start today to actually be very effective, but I want this to be built on. Yeah?
Thank you for the, comment rather than question. Henry.
I was portfolio holder in 6th and 7th. I think Lucy knows that already. I'm very worried about going into any depth on scrutiny because there are certain functions that Lucy has to do which are not only confidential, they are absolutely tied into children and their behaviour, and they can't be talked about. I would suggest that we might actually ask you to come to some of the LCNs once a year, because that would get it out to the parishes and the town councils that you were talking about a minute ago. Thank you.
Thank you very much. I think our function this afternoon was purely to look as not really to scrutinise, but to take an overview. And that we certainly have seen what a massive thing it is. And if there was to be any proper scrutiny, it would take a lot of drilling down and a lot of time. I do think there's some merit at some point in actually I don't know what you call it, a grand committee, but of the three scrutinies, perhaps chairs, vice chairs coming together, maybe one other member from each committee or something, to look at that in future. I think it's probably a more appropriate way than here and there and there. I think that's probably a better way. But thank you very much for the time. If members, we were asked to consider exactly what we've considered it and to acknowledge it, we certainly are more than happy to acknowledge it. And to think where we go going forward, and that would be my recommendation, is that the overview should be dealt with by some joint meeting of but a kind of grand scrutiny committee. I don't know what you call it, but something else. So thank you very much for what you do. I'm not sure you've helped me to sleep tonight, but apart from that, it was very interesting and informative. Another massive topic that was covered in a very short space of time, and just goes to show how this council, working in partnership with others, does that bit about the sums, the money, whatever it is, the sums equal grading. I don't know, I was rubbish at maths. But basically, thank you very much for what you do and keep doing it.
Yeah,
I can tell the recommendations in my own way. We'll write the minutes that said I was very clear. It says here the meeting closes at approximately 3:50. I'm almost right. So thank you very much for coming. The next meeting will be in this room on the 10th of October, and probably at 10 a.m.
We're an hour then.
I know, an hour. I realise it's just an hour, not 2 hours late. But
Given better value.
yeah, got your bang for your bucks. But Thursday, the 10th of October is the next plan committee of adult health and scrutiny. So thank you very much indeed.